And Ms. Fox, are you here?
I am. Good morning.
Hey, how are you, Judy?
I'm well, and yourself?
I'm really well. Thank you for asking. Okay, and do we have a court reporter today?
Yes, you do.
All right, Haley, how are you?
Good.
Good. Okay, I will call the Green Mountain Care Board's hearing of September 3rd to order. Mr. Miller, we can go on the record.
I need 1 second.
Sure.
Okay, go ahead.
All right. Good morning. Today is September 3rd. We have a number of agenda items today. First, we'll have the Rutland Regional Medical Center presentation relating to a settlement offer in connection with the fiscal year 23 board decision on budget overage. And then we have staff recommendations for UVM Network Hospitals, Brattleboro Memorial Hospital, and Copley Hospital. First, I'll turn to the minutes of July 30th, and I move to approve the minutes.
You need a second?
I do need a second.
Second.
All in favor of approval of minutes, say aye.
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 I'm an
I will
abstention, Chair Foster.
Oh, right, of course. Thank you for noting. So the minutes are approved with 4 votes. And I also move and ask for a second for approval of the minutes of August 27th.
I move them.
I'll second. And is there all in favor, say aye.
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 Aye. And the minutes are approved. So we've noticed a potential vote on the Rutland Medical Center settlement offer. I will ask our counsel, Mark Hengsler, to swear in Ms. Fox and her team. And then after that, Ms. Fox will turn it to Rutland for its presentation.
Hey, good morning, everybody. So for anybody testifying from Rutland, what I'll ask you to do in a moment is unmute yourselves. I'll administer the oath for witnesses. And then as we did for budgets, I'll ask each of you to individually state your name for the record and then affirm the oath. That way we have each name and affirmation on the record for the court reporter. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
So Judy Fox, I do.
Jennifer Bertrand, I do.
Mitchell Baruti, I do.
All right, Rutland Regional is sworn in. I'll turn it to the hospital for its discussion of the proposed settlement offer.
All right, thank you. So good morning. I'm Judy Fox, the President and Chief Executive Officer here at Rutland Regional Medical Center. Joining me this morning are Jennifer Bertrand, our Chief Financial Officer, and Mitchell Baruti, our Chief Legal Officer. Given the demand for your time and the focus on the 26 budget and reviews and deliberations, we appreciate your time and attention in reviewing our settlement proposal. To restate why we're here today, RRMC faced a 2023 enforcement action caused by our net revenue exceeding budget. The primary reason RRMC's net revenue exceeded budget related to increased utilization from providing care to patients outside our service area and a lack of access to primary care in Rutland County. In fiscal year 2023, RRMC saw a 24% increase in utilization from patients outside the Rutland service area. The most prominent drivers of patients seeking care from areas beyond Rutland related to the retirement of an orthopedic surgeon in Addison County. This retirement resulted in patients seeking care for both orthopedic and imaging services. In addition, utilization in our emergency department increased. We correlate this to the fact that Rutland's largest provider of primary care services, Community Health, an FQHC that provides over 80% of primary care services in our region, had closed services to new patients in its Rutland office. RRMC has no control or ownership in the Community Health FQHC. It wasn't until just recently, this August 2025, that the Rutland Community Health Office reopened care to new patients. This was after a 3-year pause in failing to accept new patients to their Rutland practice. Because of the net revenue overage, the Green Mountain Care Board budget order required that RRMC pay back $5.5 million. The payback mechanism was through reduced commercial rates over 2 years, beginning in fiscal year 2025 and included in our 2026 budget. Given that our revenue overage was directly linked to unexpectedly providing care to patients outside our service area or without any control of primary care, RRMC took exception to the order and filed an appeal. Ultimately, the Rutland Superior Court appeal decision resulted in reversing and remanding the enforcement decision issued by the board. Since the original hearing proceedings and RRMC's initiation of the appeal, the Vermont healthcare landscape has changed dramatically, including both the Blue Cross insolvency and the changes at the federal level that threaten both patients' ability to afford commercial insurance or attain Medicaid coverage. Our settlement rationale is based on the fact that Blue Cross insolvency and its systematic implications were not known at the time RRMC filed its enforcement appeal. While RRMC values a structured and transparent process for both budget and enforcement actions, we understand pursuing additional regulatory proceedings at this time may not be in the best interest of all parties. RRMC is committed to partnering with stakeholders to address affordability concerns and to support sustainability across the healthcare landscape. In light of these evolving challenges, RRMC has proposed a settlement framework that promotes both patient affordability and payer solvency. RRMC seeks to reach agreement to resolve the appeal with a good faith effort that promotes affordability for Vermonters, emphasizes our commitment to preserve access to care to Vermonters, is cooperative and forward-looking, proactively advances shared regulatory and legislative goals, and prioritizes system stability. Our settlement proposal includes waiving our hearing rights and foregoing a VAPA-compliant hearing, waiving a recapture of the fiscal year 2025 commercial rate reduction that reduced rates by $2.8 million, surrendering any efforts for a fiscal year 2026 adjustment in commercial rates, essentially keeping the budgeted $2.7 million commercial rate reduction in effect through 2026. Supporting Vermonters and reducing the burden of medical debt by expanding our financial assistance program to provide full free care for any household within 400% of the federal poverty level. This is an increase from the existing full free care at 300% of the federal poverty level and positively impacts Vermonters by more than $500,000. This change would continue to position RRMC to have the most generous free care program across the state and still allow partial assistance up to 500% of the federal poverty level. We also propose initiating a pharmacy charge reduction beginning in October 2025 that is equivalent to an additional $1 million in net revenue reduction. This is in advance of the January 26 price cap that will reduce our net revenue by more than $11.5 million. And lastly, by waiving any off-ramp request to increase commercial charges as permitted under H266, which can be considered if the reduction in pharmacy rates would result in programmatic losses, which is now the case for both our infusion center and our oncology service line when considering a price cap at 120% of Medicare average prices. Rather than to look to rates to mitigate the loss of our infusion and oncology services in fiscal 2026, RRMC proposes to fund the programs using one-time enhanced Medicare reimbursement that we successfully gained through CMS's volume adjustment program. This program is linked to the utilization downturn related to COVID and was not available to pursue until this last year. As considered, RRMC's proposal exceeds the original enforcement by $1.5 million and would total over $7 million in relief to Vermonters and commercial payers. We feel that our proposal strikes the right balance of affordability, access to care, and payer stability. We appreciate the opportunity to present our proposal and can answer additional questions that you might have. Thank you.
Great. Thank you very much. I'll turn it to staff if staff has any information they'd like to share with the board.
Here,
Thank you,
one
Chair
moment, I'm gonna-
Foster.
Oh, go
Sorry,
ahead, Matt.
Mark,
You
we
can pull
can
up the
pull it
slide.
up. I have it up. I can pull it up.
Please, thank you.
We have a brief staff presentation on the RRMC settlement proposal. You see, a review and deliberations and potential vote. So just going through some of the claims here, RRMC will not seek to recoup the $2.77 million associated with commercial rate growth for FY25. You can see this is just a screenshot from our rate decomposition workbook, kind of confirming that they have not done so. You would see it modeled differently in the FY25 period had they done this in order to make the growth rates work. Similarly, the FY26 section of the rate decomp, you can see you claim that they're not amending their submitted budget to recapture the growth associated with the commercial, recapture the $2.76 million associated with the rate growth. You can see that confirmed. There's been no additional rate decomposition workbook submitted or additional budget submission. So just staff confirming that these are accurate as presented. Here are the other claims that they already went through. RMC will expand its financial assistance program eligibility to 400% of the federal poverty level at 100% discount, resulting in an estimated $500,000 in additional savings for Vermonters. The only off-ramp they're requesting for FY26 is under H266 will be to apply the receipt of, as they said, the volume decrease adjustment funding toward critical cancer and infusion treatment services. RRMC will implement pharmacy charge master reductions estimated to yield $1 million in patient and payer savings between October 1st and December 31st of this year. And GMCB staff recommends approving Rutland's settlement offer as submitted. And Chair Foster, we have potential motion language here as well.
Great. Thank you. I'll open up to board discussion. I'm happy to speak first. I would approve the settlement offer. I think it's fair. I think it's reasonable. I think it avoids unnecessary litigation costs, regulatory costs, staff burden, lawyer money, all of the above. I appreciate the proposal. I think it's a fair proposal, and I would approve it. I'll open up to other board members for their perspectives and comments. And any questions, of course.
I'm happy to jump in as well, Chair Foster. No questions. I agree with everything you just said, and I appreciate the effort that Rutland's put into creating alignment between their community needs and the state health reform efforts. And the partnership approach with legislative and regulatory efforts, I think it's a good proposal, and I would approve it.
I agree. I appreciate the settlement offer. I appreciate the efforts here. And I especially appreciate the focus on affordability and insurer solvency. And so thank you for bringing this forward to us.
Member Teachout?
I do have one question about the pharmacy charge master reductions. I'm not sure exactly what Rutland is proposing. Can you give a little more detail?
Sure. I'll ask Jen Bertrand to bring in.
Certainly. So we're exploring two options in order to effectuate this. Member Teach Out. One would be to apply the 120% of ASP to our top 3 infusion medications that we administer for the first 3 months of the next fiscal year. We're also exploring a secondary option, which would impact 10 of our top 10 infusion treatment drugs at 260% of ASP. So either way, through those two avenues, we'd be able to effectuate that $1 million in net revenue reduction.
Great, thank you for the clarification. I can also support the proposal.
I support the proposal. I agree with most of the other comments, all the other comments. I just wanted to add that I do think that this is a really, it's really helpful, and I think just important that this proposal comes this way. I think it's very transparent, and I really appreciate the willingness in this proposal to confront the healthcare affordability crisis that we have in Vermont. And I look forward to continuing to work together to try to make sure that we have a sustainability solution. Thanks.
Okay, I'm going to go ahead and make the motion then. I'll see if there's a second. Sounds like there will be, and then I'll take HCA and then public comment. I move to approve the proposed settlement agreement filed by Rutland Regional Medical Center on August 1st, 2025. In reliance on the hospital's proposed actions as detailed in that letter, I move that this board decline to take enforcement action or other remedial or corrective action with respect to Rutland Regional Medical Center's fiscal year 23 net patient revenue budget overage.
I'll second.
And I'll turn to the HCA for comment.
Yeah, good morning, everyone. We support the motion as presented, and thank you, Rutland, for your presentation. Take care.
Thank you, Sam. And I'll open up to public comment via raise the hand. Okay, hearing none, all members in favor of the motion, please say aye.
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 Aye. And the motion carries. We'll turn next to the hospital budget review and deliberations and staff presentations. Before I do that, I did have an agenda update that I wanted to make sure I announced. First, today, the staff will be presenting recommendations for standard budget conditions, which would apply to all hospitals. And then on September 10th, the staff will present recommendations for Rutland Regional Medical Center fiscal year 26 budget. There'll also be potential board vote on standard budget conditions on that day. We may not ultimately get to it. We may do it on the 12th or the 15th, but we're going to notice it for the 10th. So potential board vote on standard budget conditions on the 10th, Rutland Regional Medical Center fiscal year 26 budget on the 10th. And the staff will present standard budget conditions today. And with that, I'll turn it to Mr. Sutter.
Thank you, Chair Foster. Let me just get this presentation. Thank you. So today we're going to be going over staff recommendations for Brattleboro, Copley, CVMC, Porter, and UVMMC. We'll begin by going over a deliberation schedule and hospital objections policy. We will also walk through statute, rule, and FY26 budget guidance, proposed standard budget conditions, as Chair Foster just mentioned, and then health system finance staff will review the hospitals we're discussing today and provide staff recommendations for them. Our staff attorney, Mark Henksler, will be discussing the deliberation schedule and hospital objection policy. So I'll pass it over to him.
Yeah, thanks, Matt. Yeah, so I wanted to just put up a deliberation schedule here so that everybody has it. Obviously, this is all going to be posted or has already been posted as an agenda item, but just wanted to walk through that. On the 3rd, we're discussing the hospitals that Matt just mentioned in standard budget conditions. On Wednesday, the 10th, staff are going to present recommendations for all other hospitals. there will be a potential vote for the hospitals that are discussed today, in addition to the matter of potential enforcement on CVMC's FY24 budget deviation. And there'll be a potential vote on Wednesday, the 10th, on the standard budget conditions that are presented today. Obviously, there's a chance that some of those will extend into the 12th. So anything that's not covered on the 10th will get pushed back to the 12th or the 15th. And then, of course, the hospitals that are presented on the 10th will be voted on by the board on the 12th or the 15th. So with that in mind, I just wanted to point to the objections, hospital objections policy and the guidance. So as staff we're building out the dates for these presentations, we saw quickly that there was a mismatch between the dates that we're looking at for the next week and a half and the objection policy in FY26 guidance. So that policy states that the board welcomes written or verbal objections from hospitals as defined in statute to raise issues or concerns and for the purpose of preservation of arguments that may be raised at appeal. A hospital must submit written objections to the board before 5 p.m. on September 9th so that the board has adequate time to consider the issues that are raised. That obviously works for the hospitals that are being discussed today, but doesn't work for the hospitals that are being discussed on the 10th. So what staff are proposing is that we just have an update to the deadlines. So this would just provide the opportunity for every hospital to submit objections after its the staff recommendation has been presented. And this would mean that hospitals discussed today still must submit written objections to the board before 5 p.m. on September 9th. That allows opportunity for the board to potentially vote on any of those budgets by the 10th. Second, hospitals discussed on the 10th will be offered additional time submitting written objections to the board before 5 p.m. on September 11th. And again, the purpose of this change is to ensure that each hospital can submit written objections if it needs to after staff recommendations are reviewed. All right, so turning to a little legal overview, some of this will be a brief recap of what we talked about at the start of the budget process. So to give some general background, the board must establish a budget for each hospital by September 15th with a written decision by October 1st. The board must establish hospital budgets that are consistent with the state's healthcare goals as defined in statute. And the board has a process to set hospital budget benchmarks, which guide the board in its decision making, and that's described in rule and also at 9456 E4 now with the updated Act 68. Hospitals bear the burden of persuasion in justifying their proposed budget, and if a hospital does not meet its burden, the board must adjust the budget to ensure consistency with the state's healthcare goals. This slide should look familiar. This is the decision tree that staff use to arrive at recommendations for the board. So what you see here is that the staff first question is whether a hospital met benchmarks, which are defined in section 1 of the FY26 guidance document. If a hospital did not meet benchmarks, staff turn to a analysis comparing certain hospital data points to a peer group. If the hospital does meet benchmarks, staff skip that step and either way arrive at a review of the hospital's budget assumptions. Staff, after reviewing those assumptions, either recommend approval or recommend that the board consider adjustment. And after the board receives those staff recommendations, it deliberates, it reviews those recommendations consistent with its obligations under statute, and then makes a determination based on its statutory charge. So walking through these briefly, I'll just go through each section so that we're all on firm footing. Section 1, the authority to establish benchmarks, again, comes from 18 VSA 9456 E4. And that part of statute states that the board may establish a process to define on an annual basis criteria for hospitals to meet, such as utilization and inflation benchmarks. The board may waive one or more of the review processes listed in subsection B of 9456. And those review processes include a number of items, but most notably the process of holding hearings on hospital budgets. So this year we had 3 hospitals that met benchmarks, were reviewed by staff, and staff proposed that those hospitals have their hearings waived, and the board voted to waive those hearings. Second, the board establishes benchmarks for hospital use in developing and preparing budgets. There's a process of meeting with stakeholders to obtain input, and then the benchmarks are provided to hospitals by March 31st. Benchmarks help the board consider whether budget adjustment is necessary and allow the board to exempt hospitals from hearings. That was what I was discussing prior. And just a note that an exempted hospital under rule will not have its budget adjusted. So those 3 hospitals that had their hearings waived will not have their NPR, their commercial rate, or their operating expense adjusted from what was submitted. This year, the benchmarks were 3.5% growth in net patient revenue, 3% growth in commercial reimbursement rate, and 3% growth in operating expense. So for hospitals that didn't meet those benchmarks, the process that staff employs is in Section 2 of the guidance document. This section explains how staff evaluate proposed budgets that don't meet the benchmarks. Where appropriate, staff compare hospitals to peer groups and use metrics such as operating efficiency, price, access, and quality. There's a list of items that staff have noticed as potentially reviewing, and a list of peer groups, and then staff make decisions about what items to review and compare to peer groups based on the hospital's budget submission and based on the benchmarks that were not met. Just to note, staff don't set individual benchmarks for each of those measures. That's not what that purpose is really intended to do. Instead, staff compare hospitals to their peers to understand if the above benchmark proposal is consistent with peer experience. And both peer groups and hospital metrics, again, are included in guidance and are on the board's website. Turning to Section 3, this is the section that applies to all hospitals that did not have their hearings waived. This section explains how GMCB staff evaluate proposed budgets. Regardless of compliance, each hospital bears the burden in justifying its budget. Staff review budget submissions for consistency and accuracy and compare assumptions to prior budgets and to actual hospital performance. Staff may use external data sources to evaluate hospital budget assumptions. That's described in guidance. And then taken together, Sections 2 and 3 form the basis for staff recommendations. And turning then to Section 4, the board gets those recommendations. That's what we're doing today, and then evaluates whether and to what extent budget adjustment is necessary for each hospital based on its statutory charge. Staff recommendations assist the board in its review, but the board must establish budgets that meet statutory criteria. And when we're talking about the board's statutory charge or meeting statutory criteria, what we're primarily talking about is first the section of 18 VSA that describes the General Assembly's intent in establishing the GMCB. Second, the principles for healthcare reform. And third, the hospital budget criteria that are established at 18 VSA 9456C. So what I will do is briefly walk through these in part, just to lay out what the board statutory charge is. And I'm going to start with 18 VSA 9371, which are the principles for healthcare reform. This section, in addition to another section of the board's chapter in Title 18, states that the board must execute its charge consistent with the principles for healthcare reform. And in part, there are more of them than these, but in part, those principles include 1, the principle that universal access to high quality, medically necessary health services is available. Systemic barriers such as cost must not prevent people from accessing necessary care. 2, health costs must be contained. Growth in spending must balance the needs of the population with the ability to pay for such care. 3, the system must be evaluated regularly to improve quality, access, and cost containment. 4, unnecessary expenditures must be eliminated. This includes administrative costs that do not contribute to efficient, high-quality services or improve health outcomes. And 5, the financing of healthcare in Vermont must be sufficient, fair, predictable, transparent, sustainable, and shared equitably. This next section is the intent of the General Assembly to establish the board. And here, I won't go through each of these, but you'll see the intent to establish a board to promote the general good of the state by improving the health of the population, reducing growth in expenditures for health services, enhancing patient and healthcare experience of professional experience of care, recruiting and retaining high-quality healthcare professionals, and achieving administrative simplification in healthcare financing and delivery. And then finally, 9456 is the board's budget statute. And this section has a number of areas that the board reviews and considers. And I will go through these. The board looks at Vermont's critical health needs and resources, actual hospital performance with respect to past budgets, utilization information, the efficiency of the hospital's operations, hospital administrative costs, financial contributions to a hospital network, and if those expenses are consistent with the principles for healthcare reform, the salaries for hospital executives, including variable payments and incentive plans, and if these are consistent with the principles for healthcare reform, a comparison of hospital executive salaries to the salaries of the lowest paid hospital employees who deliver direct care, public comment on all aspects of hospital costs and use and on individual budgets, and the benchmarks established by this board. So in overview, the board is tasked with establishing hospital budgets that meet the state's statutory objectives. These objectives tie back to increasing access, improving quality, and containing costs. Each year, the board establishes benchmarks to focus its analysis and to aid discussion with hospitals. Each hospital bears the burden of persuading the board that its proposed budget aligns with the state's statutory objectives. The board also votes on standard budget conditions that apply to all hospitals. Those conditions are incorporated into the budget orders and will be discussed today in a proposed form. Okay, so turning to the standard budget conditions, I'm going to start with a slide that we presented at the beginning of the hospital budget process and then turn to a few new items. So first, I'll just explain what's here. So what we did was we started with the conditions that existed in each of the FY25 hospital budget orders. And then anywhere we were making a substantive change to the proposed conditions for FY26, we underlined an item that is new or struck out in red an item that staff are proposing to remove in the FY26 standard conditions. And what I'll do is I'll just explain high level what's here rather than reading each individual condition, especially since many of these are repeats from prior years. But I'll point out the substantive changes. So the first substantive change is that staff are proposing in addition to a total NPR cap for each hospital, a commercial NPR cap for each hospital. So that would be a condition that states that the hospital's commercial NPR shall be no more than X, and the figure that staff are using is either the figure that was presented by the hospital in its rate decomposition sheet if the hospital's budget is being approved, or modified based on the hospital's rate decomposition sheet if staff are recommending modification from the hospital's proposed budget. Second, there's a more technical change than anything of just changing language to from commercial negotiated rate to commercial reimbursement rate. That's a minor item, but I'm just calling it out. The third item is that instead of capping overall change in charge at a specific percent, staff are recommending that the board order each hospital to order each hospital's overall change in charge to be approved at the minimum necessary amount to effectuate the commercial reimbursement rate, but no greater than the amount identified in the hospital's budget submission or its budget as adjusted by this order. The purpose of that section is to square some difficulty that hospitals expressed last year with the flat cap on the commercial, or sorry, on the charge growth. And then turning to the next slide. The only two items here are first, staff are recommending striking item G, which was a requirement from last year that hospitals make necessary changes to their methods of data collection to report revenue segmented by payer type. Staff believe that hospitals are all able to do this at this stage, and this condition is no longer needed. The other item is in J, which is that in addition to the hospital's duty to provide to the board an audited financial statement. If the financial audit is not available by January 31st of 26, the hospital shall provide a letter to the board explaining the delay and an audit in draft form. And turning to the next slide. This slide is just items that staff are recommending be removed. The first recommendation is that the board remove the requirement that each hospital develop and maintain a system to measure and report to the board referral lag and visit lag for primary and specialty care practices and the 5 most frequent imaging procedures. Reason for this change is that staff have included this as a reporting requirement in guidance, intend to do so going forward, and that reporting requirement in guidance is sufficient to cover this. An additional condition in the budget order is not necessary in staff's opinion. And then the other item that staff are recommending be removed is item O, which is the requirement that the hospital shall participate in the board's work, including the community engagement process pursuant to Act 167. And this recommendation is just based on the acknowledgement that the transformation efforts have turned over to AHS at this point, and taking this out of the budget orders at this stage seems reasonable based on what the board's purview is. And then going on to the next item. Okay, so I have a few additional budget conditions that I'm going to go over. I'll explain these each. These are all proposals from staff, and board members can ask any questions about these or provide comment. But I'll just go through each of these. I believe there are 3 in total. So first is a proposal to make a modification to the commercial the commercial reimbursement rate language that we just went over. And that recommended change is based on Act 55. So a little background on Act 55. This act, which was formerly H266, was ratified on June 11th. It limits some hospitals' reimbursement rates for outpatient drugs. The hospitals that are impacted shall not submit claims for outpatient administered drugs exceeding 120% of the average sales price as calculated by CMS. This does not apply to independent critical access hospitals, meaning critical access hospitals that are not part of a network. Hospitals may not increase amounts for other services to offset these rate reductions without demonstrating need to the board. The board needs to approve any requested offset, and these reductions must be considered when establishing budgets. So what staff were working on was addressing how to best capture a commercial reimbursement rate cap, and while also acknowledging the additional financial impact of Act 55. So on the next slide, I'll go over what staff's recommendation is. So first, staff are recommending that the language presented before remain as is. So again, that language is that a hospital's commercial reimbursement rate is approved at not more than the percent the board determines over current approved levels, with no commercial reimbursement rate for any payer at more than that amount over current approved levels. The commercial reimbursement rate overall or with respect to any payer may be less than that amount as negotiated between the hospital and payer. The hospital's overall change in charge is approved at the minimum necessary amount to effectuate its commercial reimbursement rate, but no greater than the amount identified in its budget submission or its budget as adjusted by this order. The new item is the underlined portion below, which is that this commercial reimbursement rate cap shall apply only to services not capped at 120% ASP for outpatient prescription drugs as defined in Act 55, Section 4. And the impact of this language to start, this language would be included in every hospital budget order, but of course would not make any change for hospitals that are not subject to Act 55. But what this does is it just clarifies for hospitals that are subject to the ASP cap in Act 55. It clarifies that the percent amount above does not apply to those services that are already capped. So I might turn it to Matt if there are any questions about the language here and explaining it, but the concept is that this would take care of and factor in those reductions in Act 55 rather than having staff model those reductions into its proposed reimbursement rate cap. All right, I'll turn to the second item. The second item is a acknowledgement of the board's new authority to review service line reductions and eliminations that are proposed by hospitals. And that new authority comes from Act 68. So I'm going to quickly review Act 68, this one little piece of it. Act 68 was ratified on June 12th, and Section 5, which took effect on passage, includes a new requirement that hospitals provide notice of certain proposed service reductions and that the board review these proposals for consistency with state goals. GMCB staff are drafting a notice of service reduction policy, which will be presented at a board meeting for comment before being finalized, and hospitals will be subject to this new policy once implemented. So acknowledging that policy, if we go to the next slide, staff are simply recommending a condition that requires each hospital to comply with the notice of service reduction policy adopted by the board as consistent with 18 VSA 9456E2. Third item. So to discuss this item, I'm going to give a little background on federal price transparency law, and then I'm going to describe a condition that staff are recommending to ensure that Vermont hospitals are up to speed on meeting the requirements of federal law on price transparency. So as a starting point, in 2019, an executive order was issued requiring CMS to adopt hospital price transparency rules, which CMS finalized. Those are at 45 CFR 180.10 to 110. And those rules required each hospital by 2021 to publish 2 price transparency tools. The first is a comprehensive machine readable file with all hospital items and services. And the second is a consumer-friendly display of 300 shoppable services. Shoppable services is a defined term in the reg. So that requirement again started in 2021, and there has been a delay. I really think across the country in hospitals expediency in meeting these new federal requirements. Because there's been a delay, CMS has turned to enforcement of these rules with civil monetary penalties. And what we've seen since 2021 have been a number of CMS investigations and notices of noncompliance, which have resulted in anywhere from fees of, at the low end, $30,000 for hospitals that have not met these federal requirements to fees at the high end of $900,000. And we've seen, I believe, 20 some hospitals that have nationally that have gotten penalized from CMS for not meeting these requirements. This July, in response to another executive order, CMS proposed rules to strengthen this section and facilitate more efficient enforcement. So our understanding is that these rules are not in any sense going away, and that CMS is working on becoming more efficient with enforcing these rules. So again, thanks. Yeah. So again, hospitals are required to publish standard services in 2 ways. The first is as a machine readable file for all items and services. That machine readable file must include gross charges, discounted cash prices, payer specific negotiated charges, and de-identified minimum and maximum negotiated charges. And second, hospitals must have a consumer friendly display of 300 shoppable services. This display must include a plain language description of each service, corresponding ancillary services, and most items listed above. And it must be available online, free of charge, and searchable by service description, billing code, and payer. I'll just add that a shoppable service, in brief, is a service that a consumer would reasonably have the opportunity to shop around for, not an emergency service for which a consumer would be going to the nearest hospital without any consumer choice. To the next slide. Looking at the state of the federal law and CMS's enforcement actions on this law, GMCB staff have determined that many Vermont hospitals appear to still be out of compliance with federal price transparency law. Staff believe that compliance with this price transparency law supports Vermont's healthcare goals for 2 reasons. First, the Vermont health system cannot afford unnecessary civil monetary penalties. And if CMS is working to ramp up its enforcement, avoiding unnecessary civil monetary penalties is a goal that really lines up with the board's authority. those penalties would likely raise commercial premiums, or they would erode hospital reserves, which we just can't afford. Second, transparent prices do allow Vermonters to seek best value. Paying less for care at hospitals with lower prices increases affordability, and it decreases system-wide commercial spend. Turning to the next slide, staff believe that ordering compliance with federal price transparency law is consistent with Vermont's healthcare goals and the board's charge. I'm going to go over some of the items that we discussed earlier. So there's the principle for healthcare reform that overall healthcare costs must be contained. The principle that the healthcare system must be transparent in design and accountable, that Vermonters should be aware of the costs of the health services they receive, and that costs should be transparent and easy to understand, that individuals have a personal responsibility to both maintain their health and to use health resources wisely, and that all individuals should have a financial stake in the health services they receive, that Vermont's healthcare system must include mechanisms for containing all system costs. So with that in mind, staff are proposing a condition applicable to all hospitals. And the condition would state that to the extent the hospital has not already done so, consistent with its obligations under federal law, the hospital shall publish by January 1st, 2026, a comprehensive machine-readable file with standard charges for all items and services as defined in the federal reg, and a consumer-friendly display of standard charges for shoppable services as defined in the reg.
Thanks, Mark. Before we begin staff recommendations, Chair Foster, would it be your preference that we pause at the end of each hospital for board questions, or would you like us to go through all of them and save those for the end?
Why don't we pause? Actually, do you mind if we take a 5-minute recess and then we'll come back? But I think we'll do a pause because it's just hard to keep all of this in our heads.
Thank you.
Okay. All right. So we'll take a short recess till 9:20 and then we'll resume. Okay, Mr. Sutter, if you're ready, I think we can resume.
Thank you, Chair Foster. Let me get the slides back up. Thank you. We're going to start, as mentioned at the outset, with the staff recommendations for Brattleboro Memorial Hospital. I'm going to pass it over to my colleague, Emma Runya, who's going to discuss their budget submission and staff's recommendations.
Great, thanks, Matt. We can go next. So good morning, everyone. I'm going to start us off with Brattleboro. I will note that I'll try to go a little slower through this one because these slides are going to get used over and over again for the hospital. So really want to make sure everyone's understanding the purpose of each of them. But besides that, I'm just going to dive right in. So first, we're looking at their submission status. Materials were generally received on time for Brattleboro. However, there were and continue to be significant issues with their budget submission. Often things were incomplete or inaccurate, and staff has met and is continuing to meet with hospital leadership to discuss these issues. Looking next at some legislative impacts. So Mark already discussed some of these, so I'll try to be brief, but generally speaking, Act 55 is dealing with that 120% of the average sales price as calculated by CMS for drugs administered in an inpatient or office setting. And so we asked each hospital, or we looked at each hospital to see what that impact would be. And for Brattleboro, from their budget review questions received 8.5, they believe that they'll be exempt from this new pricing due to their participation in the Rural Community Hospital Demo Project due to being reimbursed like a critical access hospital. They did note during their testimony that if they were not exempt from Act 55, this would be about a $4 to $5 million annual net impact. Staff obviously hasn't been able to verify that or anything because we haven't seen any of that modeling, but that is generally the around ballpark number of what Brattleboro believes that impact would be. Looking at Act 68, so there's a lot of components of Act 68 right here. We're specifically looking at considering the salaries for hospitals' executive and clinical leadership. This includes variable payments and incentive plans. And so from their narrative, Brattleboro stated that bonus and incentive pay is based on the performance of both the individual executive as well as the overall performance of the organization. And their board finally has discretion on whether or not to pay those and what that percentage is. And finally, this is actually from last year, Act 111. This is an act relating to prior authorization and step therapy requirements, health insurance claims, and provider contracts. And so we were directed by the governor to identify cost savings associated with reduced administrative burdens and ensure that these savings pass through to Vermonters. And so when we asked for follow-up for this, Brattleboro responded with this chart. And they say, so it looks like it's about a $58,000 impact by reducing physical space needed for their team and as well as not needing to hire an additional FTE in FY26. Looking at their benchmarks, their submission was technically compliant with benchmarks established in guidance. So their NPR growth is at 1.7%, which is under guidance, 3% for commercial rate growth, which is at guidance, and their operating expense growth was at 1.8%, which was also under guidance. So on the left here, we see a history of Brattleboro submitted versus approved rate increases. So the blue is going to be submitted, orange approved for those bars, and then those dashed lines are for the submitted and approved system, just so we can compare to what was generally submitted and approved for that year for across hospitals. I do want to note that prior to FY25, that's going to be changed in charge for Brattleboro and for all the hospitals rather than for commercial reimbursement rates that we're talking about today. And then on the right, we see that we've got the components of their NPR growth broken down. So we'll get a little bit more into utilization and the rate in depth in later slides, but generally speaking, there are no assumed changes in their payer mix that would be impacting that NPR. They're assuming a decrease of 1.3% in utilization, again, in not 1.3% overall, but 1.3% as contributing to the NPR growth. This is offset mostly by their rate, which is an increase of 2.3% in the NPR growth, and then other is another 0.7%, which based on the rate decomp appears to be some modeling, some increase in utilization in outpatient due to imaging. So then looking at their commercial rate a little bit more closely. So again, Brattleboro didn't break out the impact of H.266 because it's not included in their budget. Brattleboro is requesting a 3% increase in commercial reimbursement rate, which would be effectuated through a corresponding charge master increase. In the rate decomp, the maximum rate modeled is less than 3%. However, that maximum request, so that in that top right, is hard-coded in at 3%. And so we believe that this aligns mostly with their request and may also correspond to their charge master increase. And we can see from their narrative a little bit more there about their charge master and how they're going to effectuate that. But it does overall effectuate reimbursement rate is an increase across all payers, so including public payers and commercial at 1.5%. And that commercial NPR growth exhibit in that bottom right corner there is meant to show that the impact on commercial payers as the commercial NPR as a percentage and as a dollar amount. So again, we see that slight decrease in utilization, which is essentially offset by that uptick in other, which we again believe that is utilization in another sense. So the drivers of the actual utilization include shifting that ED staff from Cheshire to Blue Water, as well as increased imaging from MRI, which was modeled in other. So those essentially are flat. And so then rate is modeled at about 1%, which again, keep in mind, this is a contribution to NPR. This won't always match perfectly to the requested rate. However, we would expect this to be slightly higher based on a 3% commercial rate request. And so based on the modeling, rate would essentially contribute to all of the growth in NPR because utilization and other, again, essentially cancel each other out and are both essentially encompassing utilization. So Brattleboro, for things held harmless and requests, again, they are exempt from they believe they're exempt from HR 266 based on their cost-based reimbursement in this program. Staff does believe that Brattleboro could be subject to Act 55, and the hospital's assumption that it will not be, we feel is a pretty large risk in their budget. So just need to put that out there. So on the left, these are the rates for Medicare Advantage as given in July 2025, and we'll be comparing that to the right side of with Brattleboro's assumptions. So that first line where it says a percentage and modeled, that's coming from the rate decomp, and then underneath that is what if it is spoken to in their narrative, it says. So first we see that Medicaid rate is modeled at about negative 0.7%, and then the narrative spoke to 0%, which is roughly what we believe to be true. Brattleboro is considering voluntary participation in the Medicaid Global Budget Program offered by the state for FY26. For Medicare, we see that they're modeling 5.5%, but and then in their narrative, they also noted that it would be 2.4%. However, based on their acceptance into this program, the RCHD program, they are now anticipating cost-based reimbursement through 2028, so this could be impacting that reimbursement rate as being higher than that. And they also said that they are seeking to partner with a Medicare ACO for their attributed volume, as well as hoping to approve upon OneCare Vermont results, with ACO participation focusing on quality, which in turn would lead to achieving incentives in alignment with their long-term vision for population health. Looking at their budget assumptions, so this is looking at utilization. So on the left side, there's a lot going on the side. So on the left side, we've got utilization modeled budget to budget. So this is broken down by major service lines, so inpatient, outpatient, and professional as it relates to NPR. Whereas on the right side, this is coming from an adaptive submission. So this is a stat sheet, and this is 25 projections over 26 budget. And so if we're looking at inpatient starting on the left, we see that that's remaining flat budget to budget. Typically, Brattleboro receives an additional $3.6 million from Medicare inpatient revenue since they are typically considered a Medicare-dependent hospital, and they also have a low volume adjustment program. But they stated that the RCHD program should be similar in reimbursement for inpatient. And then if we look at the right side with those acute patient days, we do see a dip projected to budget in acute patient days. It's unclear to us what the driver of that is, but they did state in their 26 budget that this reflects the current run rate for 25 for the majority of their departments. And then looking at outpatient here, there's a drop of about 1.8%, as you can see on the left side there. They did speak to losing some professional fee revenue in the ER, again, due to switching from Cheshire Medical Center to Blue Water Health. And their projected budget appears to have a jump in observation units. So we see that on the right, increasing by 8.2% with somewhat of an offset drop in physician visits by 4%. And then looking at ancillary services, we see a decrease in 2.1%. And in the narrative, they spoke to a few initiatives to reduce ER visits with a mental health urgent care program, as well as readmissions with a collaboration with Grace Cottage. We're not 100% clear on the timeline for that, but that was what was spoken to in the narrative, and professional remains flat in the rate decomp for utilization. Looking at average salary, so on the left here, this is based on the submitted FTEs and the labor expense from the supplemental workbook. The FTE tables on the left show that there's about a 2.5% growth in clinical physician salary year over year, and nursing, it's about 4%. And then if we look at non-clinical total, that's about an 8.5% growth. And then looking at the travelers, we see there's expected to be a clear drop in travelers, so there's a reduction of 47.5%. And so importantly, we just wanted to note here that their labor assumptions are believed to be budget to budget, and that they did not provide estimated FTEs for travelers. So those are excluded from the average salaries. Now on the right here, these have been updated in response to a hearing follow-up. We see some pretty large shifts in regards to the categories. And so we think that this is more likely due to reporting changes. We just got this information last week, so we haven't been able to dig fully into it, but we'd like to just put out there that we think that these are likely more due to reporting changes rather than actual changes in what they're seeing for those FTEs. They've mentioned several administrative projects in progress, such as restructuring and centralizing registration, as well as natural attrition coupled with a hiring freeze, because overall their budget is expecting a total labor expense decline. FTE counts are budgeted to decrease by 513, and actual wage expenses are targeted to decrease by 1.5 million budget to budget. So then this is, again, another piece of the legislation for Act 68 that directs us to provide a comparison of base salaries and total compensation for the hospital's executive and clinical leadership compared to those of the hospital's lowest paid employees who deliver healthcare services directly to patients. When we asked for this in follow-up, Brattleboro gave us this qualitative response, which states that they were recognized by the Lown Institute as the best hospital in Vermont for pay equity, which they measured using their CEO's comp in comparison to a median EVS employee. So it's helpful, but not exactly the ratio that we were looking for. Looking at their assumptions for operating revenues and expenses. So we've got the revenues here in orange and then the expenses in blue. So we'll start with the expenses. We can see from this bottom bar chart here that they've been over budget in recent years. So again, kind of just orienting ourselves, each blue bar to the right of that 0%, that increase represents going over budget. And so that we see that prior to FY22, there was less variance overall, but 22 to 24, there was significantly more variance. This ranges from a 3.9% to an 8.2% overage. And then if we look at revenues to the right, we see that there are variances in both directions, the largest being in FY22 with a $3 million overage, or 3.5%. And then when we look up at that line graph, again, the same coloring, we see that since 2021, expenses have exceeded revenues. And in FY24, revenues came in under budget for the first time since FY21. Looking at previous assumptions for Brattleboro in terms of pay by split by payer, we can start at the top with commercial. We see, again, fairly large swings in both directions from FY18 to FY22. Some years are over budget, some years are under. However, we do want to note that FY23 is extremely close to budget for commercial. Looking at Medicaid, we see that actuals are consistently coming in under budget. This is by almost as much as 31% in FY22. And once again, 23 looks much closer to budget. And then finally for Medicare, similarly, it's been typically consistently under budgeted since about FY18 by as much as 18% in FY21. And then again, we see that 23 is looking closer to budget, but overall, we're seeing kind of large swings for variances across payers. When we look a little bit more specifically at Brattleboro's projections for 25, we begin to see some of the evidence of submission issues that we've had, as it appears payers may be miscategorized in the submission. So for example, here, if we're looking at that commercial other bucket, there's clearly an amount budgeted there, but they've not put any of that into their projections. We also see this happening if you look at the Medicaid in-state versus in-state FPP. It looks like that was budgeted in in-state for the budget, but then for 25 projections, it was put into FPP. So again, these kind of reporting differences just make it a little bit more difficult and challenging to see what the actual trends are. We see this also in the Medicare, in the large increase in Medicare compared to budget and the large decrease in Medicare FPP compared to budget. That 69% increase in Medicare, or 69% overage, and the 43% drop in Medicare FPP. So to take all of this together, we see it can be difficult for us as staff to determine where their actual variances are from their budget to projections versus where there just seem to be inconsistencies between last year's budget submission and the projections for this year. There's a lot of data on this slide. I'm going to try to take it slowly and kind of just gives us some high level points. Starting on the left, this is operating income, operating margin, and then total income and total margin. So then we've got this split by budget and actuals. So if we see from 21 to 25, Brattleboro has been approved for a budget with a positive operating income and margin, but they've been unable to realize that positive income or margin any of those years. We don't have actuals yet, of course, for 25, that's projected. However, they're currently projecting a loss of 2.8 million in FY25, and year to date, their operating loss is actually higher at $10.8 million. And then looking at that chart on the right, again, kind of orienting ourselves, noting that red values here indicate actuals being under budget. So that's the delta, that's not the change, that's not the actual amount, that's the change between budget to actuals. And so again, those red values indicate actuals being under budget and black indicates actuals being over budget. So we see that NPR has often come in under budget with the exception of 2019 and 2023 where it was just slightly over. Whereas other operating revenue has historically come in over budget. This has allowed their total operating revenue to be positive, looking at 22 and 23. However, this was still not enough to cover the fact that their total operating expenses also exceeded budget both of those years. And we see that even more drastically in FY24, as total operating revenue was $1.6 million under budget, and total operating expenses was $5.1 million over budget. So that leads to an operating loss that was $6.6 million under the budget. So we're going to look at a couple of ratios in financial health. We're looking at days cash on hand, days in patient accounts receivable, and age of plant. I first want to note that for Brattleboro, there are several years of missing data. So we're actually unable to calculate age of plant for 23 through 26. Days in patient accounts receivable, we can still calculate, but of course it could be affected by the fact that we don't have those uncollectible accounts in there. So looking first at days cash on hand, this continues to drop. Brattleboro did state in their hearing that they're currently maintaining 100 days cash on hand to meet their bond covenant. However, it appears that FY25 projections and FY26 budget is below that 100-day mark. You can see there it's at 90 and 93 respectively. According to the S&P Global Ratings, this days cash on hand amount is classified as vulnerable. Looking at their days inpatient accounts receivable, this is extremely high. We see that since 2023, it's been above 80 days. Typically, a below average performing hospital is considered those with greater than 50 days in patient accounts receivable. So this would be considered an extremely poor performing days in patient account receivable. And finally, age of plant, again, we were unable to calculate the age of plant, but we can assume that it's probably still relatively high. The last number we have in there is for 2022 at 15.7, which would be considered highly vulnerable. So now looking at some price transparency values, I want to first emphasize that for this slide and for remaining slides on price transparency for this hospital and all others, we are looking at facility and technical fees or / technical fees, just excluding professional entirely. And so from what we take from this is that we've got the gross charges and then we've got the percentage of gross for the select services. What we can take from this is that Brattleboro appears to be fairly consistent across services. Again, this is a small sample, so there is no guarantee that, for example, Blue Cross pays 90% of gross for every single service, but we do see that there's generally consistency, and here that Cigna and United are paying at a higher rate than Blue Cross and MVP for these services. So then this one is comparing negotiated rates. We're just taking Blue Cross and Cigna for a set of these services. So the min, average, and max amounts here are for Vermont hospitals that have a negotiated rate for that service. Red here would signify that the negotiated rate or value is higher than the state average for that service, while the green signifies lower than average. And so what we see for Brattleboro is that they actually have the lowest rate in the state for Blue Cross Blue Shield for a low complexity PT evaluation. That's that 223 highlighted there. The moderate and high complexity evals are also below the average, and all complexities of those PT evals for Cigna are below average as well. We do note that their ED visits are higher than average for both payers. Again, going back to what Mark was discussing earlier, looking at compliance with the federally mandated price transparency. Again, there's those two components, the shoppable services and a machine readable file. Overall, most hospitals in Vermont are compliant with the machine readable file. However, several are not in compliance with the shoppable services. And so that's what we're going to focus on here. The shoppable services, again, requires that a hospital maintains an internet-based price estimator tool that meets a variety of requirements, including the negotiated rate for the service, de-identified min and max allowed amounts, cash discount price, along with requirements such as that the estimate is free, that there's no PII required, no user and password, things like that. So Brattleboro does not require specific insurance or personal information. You can see right there at the top left that you can search and select services and payers, and that shows all available. And then you can see at the bottom here, when you do select one, so this is one example, it shows you all the required information. So overall, Brattleboro appears to be compliant with both the shoppable services and the machine readable file requirements. Looking at payment to cost ratio, I know we talked about this a little bit in one of our earlier presentations. So I just want to first remind everyone on this slide and those that follow based on the payment to cost ratio from the cost coverage analysis that this is based on BCURE's data. So there are some important sectors missing, and so it won't be fully representative of the hospital as a whole. However, it's a good estimate. And so if we're looking at the payment to cost ratio, we can see that on the left for inpatient, Brattleboro is and has historically been slightly below average, sitting at 120% in FY24. Medicare and Medicaid both look to be right about average at 88% for Medicare and 49% for Medicaid. When we look at outpatient, we see that Brattleboro's actually historically had a higher payment to cost ratio. Right now, it's closer to average at about 232%. Medicare is extremely below average and noticeably much lower than the inpatient at just 22%, that orange line right there. I do want to note that when in follow-up, Brattleboro said that they believe this number to be closer to 35%. However, again, this could also just be due to differences. We don't know what year that data is coming from for them. This is for FY24. And those also could be due to differences in the fact that Brattleboro has the entirety of their claims, whereas BCURE does not. And so generally speaking, Brattleboro, and then again, sorry, Medicaid is at that same average for inpatient at about 49%. And so for Brattleboro, the biggest differences in inpatient and outpatient comes from both their commercial and their Medicare, whereas payment to cost ratio for Medicaid is about consistent across the two. When we're looking at productivity, Brattleboro only provides a comparison for work RVUs to the 25th percentile. So for other hospitals, you'll see 25th, 21st, 25th to 50th, 51st to 75th, and then 75th and above. However, for Brattleboro, we only have that comparison for less than 25th or greater than. So we see here that 67% of FTEs are less than the 25th percentile. Just 33% are above the 25th percentile. This is flipped from last year. Last year, it was actually the exact opposite, and there was 33% below the 25th and 67% above that 25th percentile. We're seeing worsening productivity across the board here. Of the 11 specialties reported both this year and last, 1 has improved while 8 have worsened. And then looking over at the right, looking at the average length of stay, we again see some of the reporting challenges that we've had with Brattleboro. There's no data available for 23 or 24, and 25 and 26 also doesn't have data available for the total average length of stay. While we can look at the trend from those 22 actuals to where the 25 and 26 budget are, which you can also see is exactly identical, which we may not fully expect. What we see is that for acute and nursery, those average length of stays have increased from FY22 to FY25 projections slash FY26 budget. Looking at access, so we can start on the left here and looking at their wait times for their hospital-owned services. We see that the majority of patients are scheduled within 3 to 6 months. 0% are scheduled within 2 weeks. 21% were scheduled within 2 to 4 weeks, and just 19% in 1 to 3 months. So again, majority, those 60% are being seen within 3 to 6 months. Of the 6 specialties reported this year and last, 3 have improved while 2 have worsened. And those 2 specialties that have worsened include primary care and cardiology. On the right, we have a chart. This is typically for all the remaining hospitals going to be a chart of the 10 zip codes with the highest number of Medicare discharges. So those will be detailed, and then there's a summary at the bottom for all other zip codes that are summarized for a single hospital. However, in the case of Brattleboro, there's only 8, and there's no other zip codes. This market share is calculated by a comparison with all other hospitals having Medicare discharges from that given zip code. So the hospital's discharges from a zip code as a percentage of the total discharges to all hospitals from that zip code. So that's how market share is calculated here. And then also wanted to note that this includes Medicare and Medicare Advantage. So notably, 2 of the 3 Brattleboro zip codes have seen a drop in market share compared to 5 years prior. And generally, there appear to be larger drops rather than increases in market share, with the exception of Wardsboro. And then again, wanted to note here that Hinsdale, New Hampshire is the zip code with the 3rd most Medicare discharges. So again, seeing some out-of-state payers there. Looking at Brattleboro's quality, their current star rating is at 3 out of 5 stars, and the patient survey rating is the same. Their star rating in Q4 of 22 was also 3 stars. It did increase to 4 stars as of April of this year, but it has dropped back down to 3. So we're seeing Brattleboro kind of staying around 3 or 4 stars. Looking at that top right graph, this is for payment reductions. Brattleboro's payment bump for value-based purchasing program was 1.16%. So that's actually a positive increase. The readmission reduction program resulted in a negative 0.71% decrease. And then there was no change in payment for the hospital acquired condition reduction program. And then the bottom right graph is looking at some of our ED metrics. So we could see the average times that the patient spent in the ED before being sent home was 156 minutes, which is higher than the national average and slightly above the state average for other low volume hospitals. The median time that psychiatric and mental health patients spent in the ED before leaving is 920 minutes, which is far higher than the national and state averages. And finally, the percentage of patients who left the ED before being seen is at 4%, which is double both the national and state average of 2%. We wanted to talk a little bit about an independent observer. So Act 49, which was formerly H.482, 482, was ratified June 5th, 2025 and took effect on passage. So Section 2 of this provides the board with new authority to appoint an independent observer upon finding that a hospital has made material misrepresentation in information or documents. And that independent observer may be appointed with respect to any matter related to the board's budget review authority. So GMCB staff believes that Brattleboro's FY26 budget submission contains material misrepresentations. Staff believe an independent observer can assist both in regulation of Brattleboro and could assist them in their financial projections and planning.
Emma, apologies for interrupting.
Go ahead,
Mark
please.
Henksler, our staff attorney, I think wanted to speak a little bit more
Yeah,
about
please, Mark,
the
go ahead.
independent observer.
Yeah, I want to apologize. I did fail to include one portion of Act 49. I just thought I would use this opportunity to describe that now before turning to the staff recommendation. So as this slide provides, the board does have a new authority to appoint an independent observer. The board's authority to do that is limited to 2 scenarios. The first scenario is the one that's listed here, which is if the board makes a finding that a hospital has made a material misrepresentation in information or documents, it may choose to appoint an independent observer. The segment that I failed to include on this slide is the second reason that the board can appoint an observer, and that's if the board makes a finding that a hospital has been materially non-compliant with a budget established by this board. So I want to bring that up here just to give a little bit of color to this. First, my understanding is that it's not a surprise to Brattleboro Memorial Hospital that GMCB staff have been consistently concerned about the accuracy of information that's been submitted, setting aside whether that's a material misrepresentation or failure to comply to a budget order. I'll just point to a few items. As I understand it, there have been major areas of financial submissions for FY24 and FY25 that have not tied out or been accurate as far as staff have been able to discern. The FY25 budget order requires submission of FY24 actuals and requires submission of FY25 projections, and there have been issues throughout, which again, my understanding, this is not new information for BMH. There's been a lot of back and forth between GMCB staff and the hospital on this. The second point is what Emma referred to in earlier slides, which was the extent to which information that was submitted as part of FY26 budget was either financially or mathematically inaccurate or did not tie out. So I bring both of those up here just to point out that the board's new authority to appoint an independent observer it's limited to those areas where the board either finds that there's a material misrepresentation or that a hospital has been materially non-compliant with a budget, which includes the budget conditions that are included in the budget order. If the board chooses to appoint an independent observer, the purpose of that observer is to use experience or expertise relevant to specific circumstances the board is concerned about, to observe hospital operations, obtain information, and report findings and recommendations to the board to assist with the hospital's ability to comply with budget orders and or to present accurate information to the board. The observer is, if the board elects to appoint an observer, the board would do so in a separate motion from a hospital's budget. If this board wants more details presented publicly about issues that staff have seen in back and forth in budget submissions, that's something that I believe staff would be able to present to the board next week. Again, those are part of the record in the sense that they've been communications directly with the hospital, but not presented in slides to date. And the last piece is that if the board appoints an independent observer, the board has the discretion to order a hospital to pay for all or a portion of the costs of that observer, or in the alternative to have those costs be paid in a different manner. I'll turn it back to the staff recommendation.
Great, thanks, Mark. I appreciate that. So here are our staff recommendations. There's a couple options here for you. Option number one would be a level funded budget. Their submission has numerous significant issues, and it's very difficult to recommend a rate increase in our current environment without having a clear picture of the hospital's underlying finances. This would require a monitor, monthly meetings, and then resubmission if they do need an increase. Option number two gives them a weighted system average increase excluding UVMMC, which would be approximately 2.45%. So while there are serious issues with their submission, the hospital has real financial issues, and we worry about the impact of a level funded budget on access to care in that region. 2.45% would only be higher than Grace Cottage, who was submitted 0%, was exempt. North Country submitted 0.5% and was exempted, and Rutland, who is currently submitted 1.5% and potentially expect a mid-year request. So those are that would also require a monitor, monthly meetings, and a resubmission. I think that's all we have for Brattleboro. Chair Foster, I'll turn it back to you for questions.
Thank you very much. I really appreciate the depth of the material that you're providing the board. It's really significant. I'll open up to the other board members for their comments or any questions.
This is Sarah. I do have two questions. I'm not sure if the staff can answer them. The first was I noticed the very high prices on the outpatient ED visits. And I was wondering if you knew if that's because that's a contracted service.
I don't. I could look into that for you, Sarah, but I don't know off the top of my head.
Okay. And my second question is on the market share numbers you presented. And I was just curious if you thought the numbers of discharges were large enough to be statistically significant.
Yeah, that's a good question. That comes from the MedPAR or some of the Medicare reports directly. So I would like to think that they are submitting those that are statistically significant. So that would be coming straight from them. So I could double check for you. I would like to assume that they would be putting out numbers that are statistically significant, but I could double check for that as well.
Okay, that's all I have for questions. Thank you.
I have a couple questions, if that's okay, Chair Foster. The first one is actually from Mark. Mark, you just mentioned if there's an independent observer, the board could require that the cost of that independent observer be paid for by the hospital, but there may be other alternatives. What are the other alternatives?
That's the fair question. The statute does not specify, so I would have to take a little bit of a guess here, but I think that if the hospital is not paying, then the observer would need to be paid in some form through money that's available to the board. And for the sake of discussion, I do think that it really makes it a lot easier for us to consider this option from the perspective of a hospital paying for it. I would probably need to do a little bit more research and work to figure out the way to do this differently.
Okay, great, thank you. And my second question is around H266 and the drug cap. And you know, in the presentation, it seemed like it was a risk. I guess what my understanding is that H266 and the drug cap would apply to BMH. They're not an independent critical access hospital. So I guess my question, I think, is who ultimately determines whether they're subject to the drug cap or not?
Yep. So as a starting point, the designation in H266 now, the designation is that the cap does not apply to independent critical access hospitals. And we heard testimony from BMH in its budget hearing that it was making a decision as to how to move forward, and that it thought that taking on this rural redesign designation, apologies if I have the exact language there wrong, taking that designation would make it operationally very similar to a critical access hospital. The board is not issuing any order that would state that a hospital is or is not subject to the price cap. So the question of how this gets resolved is the hospital's negotiations with the insurer. And what BMH described, that was discussed in that hearing, and what BMH described was that it believed that it could, that insurers would agree, if I'm paraphrasing this slightly incorrectly, but that something to the effect of insurers may agree with BMH that it should be treated as a critical access hospital for this purpose. That's not something that staff here are planning on weighing in on.
Okay. And the third question I just had was really whether or not at the time of the hearing, BMH had not completed answers to the staff questions, the pre-hearing questions, and I'm not sure if those have been submitted. Have we seen complete answers to those pre-hearing questions? I looked quickly and couldn't find them, but I'm not sure if they're available or not.
I have not, no.
Okay, so they still have not been submitted.
That's my understanding, yeah.
Thank you. Those are my questions, Chair Foster.
Thank you. Any other board members?
So I'll jump in. Thanks for the presentation. I really appreciate the framework that you've provided and the depth of the analysis. I wanted to make sure of a couple things on the operating expense growth. I think it was slide 46. Did I read the table correctly that has been exceeding their operating revenue in several years?
Yeah, that's right.
Okay. Thanks. Then I think on no. With a question about the independent observer, I'm sensitive to Brattleboro's financial situation and the effect that a level funding decision would have. or could have on them. I'm wondering how fast an independent observer could help with resubmitting a more thoroughly completed budget, and we could then decide or reconsider an increase in their revenue, prices, operating expenses. So if we level funded, how long would we be stuck with that before we could reconsider? Could we have them back in a month? Is it 3 months? Is it a year?
Board Member Walsh, I can't say for certain. I think the hospital would have to answer that. I can say that they've told us that they're exploring contracting with the help on reporting to the board and for internal purposes. So I assume that would increase or decrease the timeline in their response, but I can't say for sure certain how quickly they can turn it around.
Okay, that makes sense. Thank you. That's all I have.
Can I ask just a general question first before I brought up a real specific question? Emma, can you remind me of in the payment to cost ratio where the calculation of cost comes from?
Sure, yeah, so the costs for those come from the Medicare cost reports. So it's allocated, you take those and they allocate them to the different areas. And so then they have the payments directly from the hospital from VCures, and then the costs come from Medicare cost reports.
Great, thank you.
Mhm.
And then in Brattleboro specific questions, I'm a bit concerned about the traveler reduction percentage being overly optimistic. Did we get any further communication? Can you remind me about that assumption, if that seemed like that there was that it was potentially realistic, or if there's an area of risk there?
I don't think we received anything further. I can double check for you, Member Merman, but I don't think we got anything further. And that's also, again, kind of pointing to other areas in their submission. I think it might be slightly unclear how much of that is actual expected decrease versus reporting issues.
Okay. Just with regard to Member T-Tap's question on the ED charges there, my understanding is, Emma, you said those were facility fees and not professional fees. So
yes.
I would assume that those are not related to the contract group, because I assume that especially as it switches to Blue Water, that my understanding is the professional fees are going to go to Blue Water now, but previously those professional fees went to BMH, but regardless, those should be not professional. That's my assumption, but I just wanted to, Sarah, when you asked that question, that was my thought on it. I'm not totally sure though. Another question for you, Emma, though, is on the resubmission. Could you sort of describe or Matt, what your thoughts are on what this resubmission process is and what we would gain from a resubmission here, and how we would sort of manage this resubmission?
Yeah, so Matt, please feel free to jump in and correct me on any part of this. But I think that the goal of the resubmission would be really to have these metrics and their financials tie. That's the main reason I think that we feel uncomfortable supporting a budget that we don't fully understand and we can't get to tie out. So I think the main goal of the resubmission would be to to ensure that we feel like those financials, we understand them. Because right now, I think the biggest concern we have is that we don't fully understand the financial picture at Brattleboro, which is concerning due to their kind of current situation. And so that would be one aspect. It's kind of the reason why we gave this second option of the approving this increase, so that they would have that growth, but then later on could go back and could still increase their NPR and their expense growth without it causing material harm. And so the main goal really is to get the financials to tie, and then eventually that budget could eventually end up being pretty close to what they've submitted here. We just don't want to approve that submission not understanding it fully. Matt, anything else I missed?
Yeah, I would just add, and Mark can correct me, but I believe the process we would do this under would be just a mid-year amended budget request from the hospital.
Okay. And so my understanding of a mid-year request, it has to be on an unforeseen circumstance, but is there a way to amend that to allow for a resubmission for clarification?
So the language in in that portion of statute is a hospital may apply for a budget adjustment upon a showing of need based on an exceptional or unforeseen circumstance. Happy to chat more offline about details.
Okay. I'm just trying to figure out how we're gonna act upon or not act upon a resubmitted budget. So maybe we can talk more about that. And then I just want to sort of highlight the days cash on hand, accounts receivable challenges that they have. It really appears to me that if the accounts receivable were back to pre-2020 levels, their days cash on hand would look substantially better. So that was discussed in the hearing, and I'm optimistic that that they're going to be able to work with that. And I guess just comments on the independent receiver, independent observer. Just quickly, I think given the sustained operating losses, they have high commercial prices. I think the challenges with the submission and my concern of their really geographic, strategic importance to their community and their region. Just broadly speaking, I'm very supportive of the concept of having some mechanism to support Brattleboro's efficient operation. So thank you.
Great, thank you. And I guess what I'll do after each hospital, I will turn to the HCA and I'll hold all public comment to the end just for efficiency, but I want to make sure the HCA has an opportunity. So I'll turn it to Mr. Peisch if you have any comments on the staff presentation.
No, thank you to the staff. I just wanted to let the board know that if you have any questions about our written comment, feel free to reach out. It's on the website, and we stand by our recommendations. Thank you.
Thank you. Actually, I'm sorry, Mr. Doherty, are you here by chance?
Yes, sir, I am.
Would you, I don't want to actually, I don't know if hospitals have comment at this time or if they want to wait, but I suppose I should make sure you have an opportunity to comment if you want it. I guess this goes for process for the whole hearing today. Would you all like me to stop and give you a chance to comment, or would you rather wait?
I'd appreciate that, Chair Foster, if that's okay.
Please, of course.
Well, thank you. Well, first of all, I did have a great opportunity to talk to Matt last week, and I really appreciated his time, his detailed conversation about the challenges that we've been bringing to Green Mountain Care Board, and I really apologize for all those challenges. We are looking at quick ways to get this resolved. As Matt mentioned, he and I discussed that we've already been looking at outside counsel or outside utilizers to actually help us with a resubmission, and actually looking at using them for fractional work to contract out our financial reporting on an ongoing basis. And we actually have a meeting today to get a proposal. To Member Merman's question, or might have been Member Wash, I believe we could turn something around in about a month's time in terms of a resubmission. And we're going to work that rapidly on it to make sure that we have an understanding. And then I think we don't want to correct anything, but we were asking about what the impact of the medication cap rate is if we are to become a rural community hospital demonstration project. And to Member Holmes' question, we were asking who ultimately makes that decision. So hearing that it's between us and our commercial insurance, we can easily start that process of working with them, but we had not received that direction. And so we will start that process rapidly as well.
Great. Thank you very much for your attention to all this, Mr. Doherty, and your help in trying to move this along. And we do support this hospital, and we appreciate your cooperation and partnership in doing that.
We appreciate that, Chair Foster. And again, our sincerest apologies, and we look forward to working very closely with Matt to keep on a good basis with Green Mountain Care Board for the reporting requirements on an ongoing basis.
Likewise, the feeling's the same. Thank you. I'll turn it back to staff for the next presentation.
Thanks, Chair Foster. I'm going to turn it to my colleague, Janelle Vigario, who's going to review Copley's submission.
Yes, thank you. So I'll just jump right in here. Copley's submission was considered late. They informed us 1 week after the deadline that they were running behind due to a late board vote on the birthing center. We can jump to the next slide. For ACT, so the legislative impact, Copley's not impacted by Act 55 since they're a critical access hospital that's not in a network. For Act 68, they say that they consider the salaries for the hospital's executive and clinical leadership, including variable payments and incentive plans. Oh, sorry, that's what the act is. Copley does not have a formal variable compensation program for its leadership. There have been discretionary bonuses from time to time, which were tied to the achievement of an identified initiative or overall performance. Reviewing their budget submission, there weren't variable payments or bonuses budgeted for senior leadership for 26 based on the supplemental exhibits that they provided. And Act 111, they responded with none when asked to quantify the expense reduction. So we can jump to the next slide. So Copley is requesting to exceed all benchmarks. So this slide presents them with no exemptions or carve out. With their requested exemptions, they are under benchmark for NPR and expenses. We'll take a little bit more of a detailed look at those on the next slide. But with no exemptions, they have NPR growth of 12.8%, commercial rate at 4.2%, and the operating expense is at 12.5%. So the 12.8% NPR growth, in the narrative, they state that the growth is driven by the opening of a fourth operating room, which will contribute to 9.8% of the NPR growth, and 4.1% of that is from the Lamoille Health Partners financial crisis. With these exemptions, NPR growth would be closer to negative 3.7%. This includes the offset of the closure of the birthing center, which has a 1.7% impact. Expense growth is coming in at 12.5% over. Similar to NPR, the main drivers is the operating room at 7.9% and the Lamoille Health Partners at 1.8%. With the exemption of those two expense growth, it would be closer to 0.8%. This also includes the offset of the closure of the birthing center, which would have a negative 2.4% impact, according to the narrative. And then the rate request is just over. There's no exemptions there, or carve out. So drilling into the benchmark, the commercial benchmark a bit further. They've had some lower requests from 2015 to 2019. In 15, they had a flat request and received flat NPR growth or flat rate growth. For 16 through 18, they requested flat or negative rates and were approved and cut for some of those. In 2019, they began requesting receiving positive rate increases again. Copley makes the justification that their prices have not kept up with the hospital marketplace in Vermont. Looking to this year for the source of NPR growth, it's a combination of mostly rate and utilization with a slight impact from payer mix. We jump into utilization and rate on later slides. Payer mix appears to be from a large jump in Medicare Advantage, offset by decreases in all other payers. And we can jump to the next slide. So Copley's rate request is pretty straightforward. It's above benchmark at 4.2%, but as stated earlier, their justification is that they are a low-cost facility and they're looking to charge a fair and reasonable price. Overall impact on commercial NPR, which is what the impact on the system would be, it's about $1.95 million in growth. There isn't a reference to the payer mix decrease in commercial in the narrative, so we're not quite clear what that assumption is. This is also showing up in self-pay, but the 4.2% increase would correspond to a 4.6% charge master increase on rate. The increases in gross charges will increase net patient service revenue, but not on a dollar for dollar basis. And then we can jump to the public payer assumption. So these are pretty straightforward. Medicaid is modeled at 0%, which is consistent with the other hospitals. Medicare is based on increase in costs since they receive cost-based reimbursement, and Medicare Advantage is closely in line with those assumptions. And then we can jump to utilization. So Copley is expecting a lot of utilization growth. The impact on NPR is 8%. So as a reminder, that 18.8% that you see in the bottom of that exhibit from the narrative, it could be in regards to gross revenues. The 8% from the rate decomp is how that translates to NPR. But that could be contributing to that difference there. So this is not new information, but the big drivers are the opening up of the 4th operating room, as well as the Memorial Health Partners crisis. They're taking on their labs, which were originally being sent to Quest Diagnostics, as well as taking on diagnostic imaging after the closure of their Stowe clinic. This is offset by the plan to shut down the birthing center. When looking at the utilization stat, there's a dip in patient days from 24 to 25 projected, with a slight bounce back for 26 budget. We asked in the first RFI how it aligned with the rate decomp. They responded that the increase on the rate decomp is a measure of volume growth as measured by gross revenues. Other notable increases in outpatient include steady growth in outpatient visits, and followed by steep decreases in observation units. This is dropping from just over 1,000 in 2024 to 60 in 2026. We're also seeing a bounce back in physician office visits after a dip. ER is modeled flat in 26 compared to 25 projections. And operating room procedures are seeing steady growth. Jump to the labor. In the narrative, Copley mentions developing a long-term contracted labor strategy. We're not exactly sure what that looks like for 26 in terms of cost. However, in the narrative, they did mention that contracted labor is expected to grow from 21 to 27 budgeted FTE. Overall, they're expecting an increase of 8.5 FTE, which corresponds to what we're seeing in utilization, which is growth in the 4th operating room, lab, and radiology, with increases in other areas as well, offset by a 14.5 FTE decrease in the birthing center. And we can jump to the salaries. So Copley provided the exhibit to the left in response to the Act 8 RFI. We created an average of senior leadership and compared it to the lowest paid clinical. That's the exhibit on the right. That comes out to about 5.5. It shakes out to about 18%. And so Copley's previous assumptions, starting with operating expenses in blue, we can see 21 to 23. There were some pretty significant deviations for Copley. Prior to that, expenses came in closer to budget, and 24 expenses are actually below budget by 4.7. If I can recall correctly, this was driven by staffing shortages. Looking at the operating revenue in orange, we see that prior to 21, Copley seemed to overestimate the revenue they could generate. However, this changed in 21. Some of this could be due to COVID-related funding, and it appears that for 23 and 24, they are closer to budgeted. Looking at the line chart, we see that most years' expenses seem to slightly outpace revenues, with 21 being the exception. Looking at net patient care revenue by payer, we see that historically Copley has not been able to generate NPR that was budgeted, with the exception of 21. This variance ranges from -2.8 to -24% below. Medicaid also seems to be inconsistent year over year, though it was under budgeted in 22 by nearly 31% and over budgeted in 23 by over 41%. Medicare seems to have historically been over budgeted from 17 to 21. In 22 and 23, actuals have come in 54.5% over. Oh, and 30.1% over. Large jump. And then for 25, commercial is coming in favorable while Medicaid and Medicare are unfavorable. Overall, that shakes out to about a 1.5% overage. So Copley has exceeded their budget in operating and total income for 24, leading to positive margins despite budgeting for a negative. In 25, it's projecting a positive operating income and margin as well, though it's not hitting what their operating margin was budgeted to be. Looking to the graph on the right, we see that the 24 NPR actually came in below budget, but was offset by much higher than expected other operating revenue. We can see historically that for other operating revenue, Copley has under budgeted since 2020 by some pretty significant percentages. Total revenue for 24 also came in slightly under budget, but expenses came in under even more so, leading to an operating income of $4.3 million more than what was budgeted. Looking at days cash on hand, Copley has improved its cash position compared to 23. However, it has hovered right around 60 to 65 days for 24 through 26. According to S&P Global Ratings, that's considered highly vulnerable. Days in patients' accounts receivable increased significantly during the pandemic, reaching 58.1 in 24, which is considered below average performance. However, projections for 25 and budget for 26 have this reducing to below 50 days, putting them back in around average performance. We'd like to see that trend continue. But yeah, it's a good goal to shoot for, around 50 days. Finally, the age of plant has been creeping up since 21, reaching 13.1 in 24. This is considered vulnerable according to S&P Global Ratings. However, it is projected to drop in 25 to 11.6 and increase slightly again in 26 to 12, which is considered adequate. We can jump to the price transparency. So looking across payers here, we see that there's generally lower reimbursement from Blue Cross Blue Shield and MVP compared to Cigna and United Health. There appears to be much more variability in negotiated rates as a percentage of gross with Blue Cross, where the other payers are more consistent across services. We're not exactly sure why some of the negotiated rates for the PT evals of Blue Cross are higher than gross. We can jump to the next slide. Again, we're comparing negotiated rates of Blue Cross and Cigna for services. The min, average, and max values are for Vermont hospitals that have been negotiated, that have a negotiated rate for that service. We see more differences between the payers here compared to some other hospitals. Cigna is closer to the average and slightly above, where Blue Cross is more often below the state average. The two CT scans listed here are the lowest negotiated rate in the state for Blue Cross, and the same is true for the selected blood culture lab. So for the price transparency, considering the requirements for shoppable services for a hospital, we see that in order to get an estimate, the patient must put in personal information. While the service is selectable, the payer is not. It is typed in by the patient. This immediately indicates that the negotiated rates by payer are not considered, as the patient can type in anything and the given amount will not change. The estimate also does not include min or max allowed amounts. Therefore, Copley appears to be non-compliant with the shoppable services, but is compliant with the machine-readable file. So this information is unavailable for Copley. There are other critical access hospitals that do have this information. Copley just doesn't have this available for 23, so we're not able to fully evaluate the efficiency. We'll just jump to the next slide. This is the payment to cost ratio. So looking at this ratio, we can see that for inpatient, Copley has historically been below average and still is. However, they broke above 100% starting in 24. Due to cost-based reimbursements for critical access, the Medicare amount is at 99%, and Medicaid sits slightly above average at 77%. For outpatient, we see a similar trend in commercial, but a higher payment to cost ratio than inpatient at 169%. Medicare is again at 99%, and Medicaid is about average at 57%, although this is a large drop compared to inpatient. The biggest difference in inpatient and outpatient comes from commercial payers, so Medicaid is a 20% drop as well. We can jump to productivity. So looking at Copley's productivity in terms of work RVUs, we see that 63% of the FTEs are below the 25th percentile, 29% are between the 25th and 50th, and 8% are above the 75th percentile. This means that over 90% of the FTEs are at or below the 50th percentile. We are unable to compare to last year due to not having benchmark data last year, but we appreciate the improvements in reporting from Copley for this year. Looking at the average length of stay, we see a steady increase in total average length of stay year over year from 22 to 26 budgeted. Acute average length of stay has had more variation, increasing in 23 and 24 before decreasing slightly in 25 projected. The 26 budget assumes only a slight increase here. For the nursery average length of stay, looking from 22 to 26 budget, it's essentially flat. Swing average length of stay is not shown here due to how it skews the graph, but it has increased similarly to total year over year from 10.95 in 22 to 17.07 in the 26 budget. So starting on the left, looking at wait times for the hospital-owned services, we can see the majority of patients are scheduled within 2 weeks at 59%. 31% are scheduled within 2 to 4 weeks, and the remaining 10% are scheduled within 1 to 6 months. Of the 5 specialties reported this year and last, 3 have improved and 2 have worsened. Looking at the chart on the right, we see more zip codes have decreased their market share compared to 5 years prior. With the exception of Craftsbury, there was a 34% increase in the market share to capture the entire market. It seems that overall Copley has lost more of their market share than they have gained, at least in the top zip codes. So Copley's current star rating is 3 out of 5 stars, with the patient survey rating at 5 out of 5 stars. Their star rating in Q4 22 was 5 stars, and then it decreased to 2 stars as of April of this year before increasing back to 3. The death rate for heart failure patients is worse than the national rate, and the ratio of unplanned hospital visits after hospital outpatient surgery is worse than expected. Copley, again, did not have data available for this reporting period on the emergency department measures. And then staff recommendations. So staff recommends that the commercial reimbursement rate is reduced from 4.2% to guidance at 3%, which is a decrease of 1.2%. We would recommend that we reduce the NPR with the commercial rate reduction of $733,000. And we recommend the expense growth is approved as submitted. And I'll turn it back to you.
Thank you very much, Ms. Vicario. I'll open up to the other board members for comments and questions.
I can jump in with a quick question. On slide 69, you have other operating revenue, and some of the percent overages are quite large. What goes into other operating revenue?
Yeah. Board Member Walsh, I could guess. I would need to get you. I need to look to give you a more specific answer. But my guess here is those are grants from COVID, causing those massive increases on a percentage basis.
Right. That makes sense. Thanks for that information. That's all I have.
I can ask a couple quick questions. I've asked this before, but I'm not totally sure. Do you know if there's additional? I was a little bit confused by the response in the hearing about additional cash at the parent company and that the parent company holds the investments. Do you understand if with regards to days cash on hand or cash reserves, if there's additional cash reserves at the Copley parent organization, or if what we're seeing is reflected for the total cash?
Oh, we'll need to follow up with that.
All right. And then with the one additional OR, the $10 million of expenses that were associated with one additional OR, do we know, I guess one is, were there additional expenses last year allocated to that? Because I think I remember there was some discussion last year about moving a sterile supply room or something to allow for this OR to be built. And then I guess that's my question. Is that the total expense of this one OR?
That's my understanding, but I think the hospital would have to confirm.
Okay, and I guess the other question is on that, maybe that if they're going to give clarification, is are part of those expenses part of the expenses associated with doing surgeries in that OR for the year, or is that expense just the expense of the physical building of the OR? I guess that's sort of something that listening to this presentation today that I wanted further clarification on. So thank you.
Just have one question for staff. I saw questions went out, I believe, last week. Do we have responses to the additional follow-up or an expectation on timing on those?
The service reduction RFI, Chair Foster, is that what you're referring to?
Yes.
Yeah, we haven't received yet. No, I would hope to have it before the for deliberation.
Yep. Okay. Thank you.
One question related to that, related to the birthing center. We've obviously had a lot of public comment, both at the hearing and in follow-up on that birthing center. I think it'd be really important to hear from AHS on this. They've been leading care transformation. They've hired consultants to develop regional planning models. So I think it's be critical to understand AHS's position on this closure. Does it align with their vision of care transformation for the state? So I would like to formally request AHS to weigh in on this closure if we could.
Any other questions or comments at this time?
Yeah, if you want to, but it's all ready to go. Cool. I'll send it right now. Cool. Thank you so much.
Okay. Yeah, sorry. I'll turn to the healthcare advocate.
Thank you, Mr. Chair, and thank you, board staff. I also want to make a very brief, I want to recognize the public comment and the passions around the birthing center. It wouldn't surprise anyone, I'm sure, to hear that the HCA has also received some of that advocacy. And we are, so I just wanted to publicly say we've heard that passion and are also considering ways to engage to chart a productive way forward. I don't think that is here and now, but I wanted to come on and publicly say that. Thank you.
Great, thank you. And I don't know, Mr. Wooden, if you're here or any of your staff has any comments at this time?
Yeah, thanks very much. I appreciate all the hard work.
It's a lot to do, certainly a lot of questions. Appreciate the concern about the non-compliance with the shoppable services. We're gonna address that as soon as possible. Just for perspective, we're looking at a 2.7% operating margin. And if you look at our history last year, this past year, 2024, we made an operating margin, but previous to that, we've had a long run of 8 years without making an operating margin. So we're hopeful this year to maybe make half of that, and certainly next year, but it is important. Our cash is of a concern. I think Member Merman's discussion is really good. My thought about cash is that I think every healthcare system can be very complicated with a parent, one member being a hospital. I think that should be sort of more investigated for the entire system to sort of say, where is the cash and how does the parent contribute or not contribute for that cash shortfall? So I think that should be looked into. Some of the consistency in reporting can be a concern. Appreciate the exceptions and at least you acknowledging them on the laboratory radiology operating room, as well as the help for the FQHC. Our costs continue. If you look at slide 75, we're much below the average commercial significantly in terms of reimbursement as well as on the inpatient side. So I think our request, I know it was a bit above the 3%, is still really important for us as we try to get closer to the average. We did have a discussion about this with the medical staff this morning, a large medical staff meeting to just talk about, when are we ever going to get to average? And I know years ago, particularly on your chart that shows 2016, 17, and 18, we were asking for 0 or close to 0, and we got significant negative reductions in our rates. So we're still trying to climb up to something that is closer to even maybe reference-based pricing. So we do need help with that because we're moving a bit, and that's very helpful, but we got to continue to be diligent with both cash and an operating margin. But these are complicated times, and I appreciate everybody's efforts. This stuff becomes really detailed and granular quickly, but thanks for everybody's help. Tough process, but that's all.
Great. Thank you very much, Mr. Wooden. It might be an appropriate time. Are we going to the health network next? Is that right?
Yeah, Chair Foster, I had some slides on the health network and shared services next to kind of as a prelude to the individual health network hospitals. So maybe it makes sense to take a break now before we get into these.
Yeah, let's do that. Why don't we take 12 minutes. We'll come back at 10:50. Great, thank you. All right, Mr. Sutter, we can resume.
Thank you, Chair Foster. Let me get these slides up. Okay, so let's jump in. So this section first, as I said, is meant to as a kind of a precursor to us discussing the individual health network hospitals. But we're going to discuss quickly the individual member contributions to the University of Vermont Network's operating gains from FY20 to FY24. A brief comparison of their budgeted FY26 network P&L against their FY24 actuals, budgeted increases to executive compensation, and then we're going to look at some numbers related to shared service growth since FY22. I won't belabor these too much, but just to or going to read every element of the slides here, but just to explain how to interpret. So basically starting from zero, which is showing the individual hospital's contribution to the overall health network's operating gains. So in FY20, they had negative $22 million in operating losses. Champlain Valley contributed $8.4 million in losses. The medical center, $4 million in losses. And if you look on the far right, Porter, $3.2 million in increases. So you can see in FY20, Porter and Elizabethtown were the only profitable hospitals. It's likely due to their cost-based reimbursement as critical access hospitals. Moving to FY21, you can see the network's finances improved to $23.6 million. Of this, the primary driver was the University of Vermont Medical Center, which contributed, sorry, the numbers are quite small. I believe that's $38.5 million. Moving to 22, the network's finances deteriorated pretty significantly in COVID. So the network lost $102 million. It looks like Elizabethtown was the only hospital that had an operating margin or operating income of $2.7 million. Largest loser again was or contribute to loss was Champlain Valley at 30.4, but the medical center also had a sizable loss of 22.7 million in FY22 as well. Things improved significantly in FY23. So you still saw the consistent losses over at Champlain Valley. CVMC had almost $18 million in losses. Alice Hyde, 11 million. All the other entities combined, another 8 million. But UVM Medical Center really drove the hospital's finances, improved them significantly. So total operating losses of negative $5 million for FY23, but of that $65 million or $64.5 million was UVM's positive contribution. So it could have been much worse. And then FY24, we did see significant improvement among the New York hospitals. So Champlain Valley only lost $2 million in FY24, Alice Hyde, $3 million, but the other hospitals or entities basically broke even or contributed to margin. You'll see the medical center continuing to contribute over $16 million to the network's operating income. So taking these 4 years in cumulatively, like what does this look like? So you're seeing the medical center having contributed over $138 million to the health network's income over this period, despite the network losing $12.8 million over the same time period. Elizabethtown contributed 32.8, Porter 11.2, and the rest were essentially losses. CDPH had almost $86 million over this time period. CDMC 33, Alice Hyde 28.7, and the other entities between under 24.5 million, home health and hospice 18.2 million in losses. So really UVMC driving over this period any real gains. If we look at on the left, you'll see their UVM Health Network's FY24 actuals. And on the right, you'll see their budgeted operating income they provided us in a supplemental workbook with a RFI. So really I want to focus on that blue bar, the third one or fourth one from the left, that other entities. That's the non-UVMC, non-CDMC, and non-Porter related elements of the health network, the health network's budget. So in FY24, the total health network generated 92 million in income. 17 million of that was driven by non-Vermont hospital members. In the FY26 budgeted operating income, you're seeing almost $6 million loss attributed to those non-UVMMC, non-CVMC, non-Porter members. So it does look like a deterioration compared to FY24. Jumping to some health network budget assumptions, they do have a fairly sizable increase for some of their network executives. So for the 14 directly comparable executive positions they provided to us, we're seeing an average increase of about 9% across them, which is nearly a $50,000 average increase. Compared to the median income in Vermont, that's kind of a shockingly large amount to me. And if we once allocate it out, you can see this almost $695,000 in budgeted network executive increases. Once it's allocated out, 67% of that to UVM, 9.2 to CVMC, 4.1 to Porter. You're seeing $466,000 attributed of the net expense allocated out to the medical center, $64,000 to CVMC, and $29,000 to Porter. Looking during their testimony, a lot of time was spent kind of discussing their shared service budget. So just looking at the raw increase, we're seeing about 6.1% year over year since FY22. Now it's important to note that includes both transfers into shared services as well as growth in the shared services themselves. So if we back out the transfers and just consider the growth, that reduces the increase to about 4.4% year over year. But that's still a pretty sizable increase, especially when you consider
prescription coverage will benefit.
Especially when you consider the dollar amounts involved. So just to contextualize that, obviously the network shared services are not a hospital, but we want to compare the relative growth of them compared to our Vermont hospital expense growth. And so if you see, I'll use the little highlighter. Up here, you can see the UVM shared service growth, including transfers, at 6.1%, adding about $82 million in network-wide. If we pull out the growth, it's about $57 million. So after controlling for transfers, the health network shared services have grown at a faster rate than any PPS hospital in our system, at 4.4%, from FY22 to the hospital's proposed FY26 budgets. If we look at the estimated allocation of this increase over that time, it's about $38 million. That's higher just in expense increase. Just the UVM Medical Center's increase in their shared service allocation of any hospital in our system, except for the UVM Medical Center. And so that's what we have to present on the network slides. We're going to jump in first and cover CVMC, then we'll do Porter and then the Medical Center after that. But we can pause here, Chair Foster, if you have any questions about these. Yeah.
Yeah, why don't we pause here? And I think Member Merman will have to step out for the CVMC presentation because he's recused. So I'll open it to the board members on the UVMHN presentation from staff.
I do have one question. Is the UVM shared services growth in addition to UVMMC growth, expense growth, or are they combined?
It's combined. So if you I think for a better approximation here for medical center, if you wanted to have two lines for them, you would have like 459 for medical center growth outside of the shared services, and then that 499 you see from the top, or the delta there as the shared services line.
Okay. And my second question is, how much has been the increase in payment to shared services by each of the Vermont network hospitals? Is that on one of the slides? If it's not, it's fine. I'm not sure if I missed it.
The increase for each of the hospitals. Yeah, it would have to be, we could provide that for you. This is the total increase. These figures here of just the growth, the 38.1 over that time, but I can give you a year by year breakdown of the increase also.
Okay. All right. Well, that's helpful to see what you have. Thank you.
Matt, this is Tom. Thanks for the presentation. I'm interested in the data that Sarah wanted as well. If I remember correctly, during the presentations that we had, there was discussion of the percent increase in contribution to the network was the same across network hospitals. And I just want to double check that because that some hospitals are much smaller. They have fewer dollars available. That's just sounds like a regressive, similar to a regressive tax. So I just want to make sure that I'm understanding that so I can think about how that affects the local hospitals' cash.
Yeah, so the way they're allocated out is on the basis of like the hospital's portion of revenue. So as long as they're allocated along those lines, like an increase is going to be allocated, I'm using scare quotes, but fairly, as long as they don't change that percentage method. I would need to think a little bit more about your regressive taxation sort of metaphor, but it's let me think about that a little bit more. I don't want to mischaracterize.
Yep. Happy to talk more.
Hey Matt, Tom, you said.
Thank you.
Can you go back to the waterfall summary graph for a minute? Yeah. So is it fair to say that from FY20 to 24, that because of given Champlain Valley's losses, that the network, and I don't think they have cash to cover those losses at Champlain Valley, that the UVM Health Network subsidized Champlain Valley $85.8 million. Is that sort of the takeaway from this slide, or Alice Hyde 28.7 or CVMC 33.4?
Yeah, I think that's a fair way to think of it. If you're just thinking about it in terms of the total network, you could think about it over this period of the network having lost almost $13 million, but as a contributor to that, UVM provided $138 million in offsetting what would have been greater losses, and vice versa for the CDPH.
Okay. And there have been a lot of statements in the past, or there have been statements in the past, how Vermont ratepayers are not subsidizing New York hospitals. But when we think about UVM's margin and the way they budget, do you think that's an accurate statement? Or do you think it's more likely that Vermont ratepayers are subsidizing New York hospitals?
I think Vermont ratepayers are subsidizing New York hospitals, yes.
Okay. And all right. I think that's all I have. Thanks.
Let me phrase that more specifically. I think, but for the rates Vermont payers are paying, I think New York hospital they would have different management decisions at the New York hospitals. They would not be able to make the decisions they did, but for the UVM Medical Center's operating gains.
Thanks.
Just a couple quick ones. Slide 88 on the executive comp. Do we know the salary increases for the nurses and techs for fiscal year 26?
Not offhand. Forgive me. I'm not 100% sure if we have access to that currently.
Okay, I think it was public. If my memory serves, we can look it up, but it was mid-single digits, kind of 3 to 6% when they had that new collective bargaining agreement. But I would like to see that before we deliberate on how these raises for the executives at a highest level of compensation compare to the nurses and the tech increases. And I presume the justification for this is benchmarking. Is that right?
That's my presumption, yes.
And then on the New York operations, this is just contribution to network-wide reserves. It's not a representation of any of the affiliation agreements or any of the money that was funds flowed to New York for physician salaries and pharmaceuticals. Is that right?
Yeah, this is just looking at the operating statements, the expenses and revenues for operations and our audited financials.
And the salary increases, those are all pre-tax or are those post-tax?
I don't know.
All right. I think that's all I had. Thank you. I'm sorry, let me just pause so that member Merman can leave. And also I should probably take, actually, before you go, Dr. Merman, I should take any comment from the HCA at this time.
Nothing from us, Chair Foster, thanks.
And anything from UVMHN? Okay, Member Merman, I'll ask you to step out and we'll let you know when we're done with CVMC. Thanks.
Thank you.
Oh, my colleague Emma Runya will be presenting CVMC's submission.
Great, thanks, Matt. So I'm just going to jump right in. So looking at CVMC's submission status, their submission was complete and on time. They were timely and responsive in follow-up requests, and they also often asked us questions. So we did appreciate the communication throughout with CVMC. Looking at their legislative impact, so they provided the following information on each of these. For Act 55, they're modeling an approximately $5.7 million impact from January to September. So that annualized impact is about $7.6 million. This roughly corresponds to the impact that is represented in the rate decomp. And this is due to the mid-year rate request being incorporated as well. For Act 68, that variable pay, this is linked to strategic goals of the organization. For FY25, the UVM Health Network Board has determined that there will be no variable payments. In the supplemental exhibits provided with the FY26 salaries, there was no variable pay listed under senior leadership as well, but that was not explicitly called out. And Act 111 from last year stated that there was no quantifiable impact noted. Looking at their benchmarks, CVMC submitted a budget that met guidance. We'll unpack the commercial rate a little bit and more in later slides. However, we're considering each benchmark to be at or below guidance, 3.5% for NPR growth, 3% for commercial rate, and 2.8% for operating expense. So again, on the left here, we've got submitted versus approved rate increase. I do want to note that UVM Health Network has not historically used change in charge. They had their own separate commercial rate. So there is a slight difference for this graph and for the subsequent UVM Health Network charts compared to other hospitals. Then looking at the right, this year budget to budget NPR growth is coming in at 3.5%, which is historically lower than what's been requested and approved over the past few years. We're going to look at this growth kind of backwards. So this growth is mostly driven by favorable collections compared to what was budgeted in 25, according to their rate decomp. So that's that 4.2% increase in other. So that favorable collection rate is for all payers. It's particularly in Medicaid, and they did also receive extraordinary relief funding for Woodridge, as well as, but this is also there for commercial and other, for workman's comp and public agency. They're also anticipating a 2% increase in utilization. However, these two are offset by payer mix, which in the rate decomp CVMC is showing negative shifts in Medicaid, self-pay, and Medicare, but this is more than fully offset by Medicare Advantage, as well as a negative 1% offset in commercial, which overall comes out to that negative 1.5%. And rate is broken down in the following slides, but the overall impact on NPR is a negative 1.3%. So CVMC has a negative 3.6 major commercial rate. This includes their mid-year rate reduction, which reduced the pharmaceuticals down to that 120% of ASP starting in August rather than in January. So this would also overlap with FY26 for October through December, and it may also include the reduction to some commercial fee schedules, which is modeled to be about $3 million starting in August of 25, where this was not separately called out in the rate decomposition sheet. So when we back out that H.266 annualized impact, the rate request is approximately 2.3%, and there's a requested charge master increase of 3% as well. So the overall impact on commercial NPR, which is generally, or it's more specifically the impact on the system, including rate, utilization, and payer mix, is at $4.5 million in growth that we can see in the bottom chart there. Looking at their budget assumptions, so in the rate decomp, they modeled Medicaid as a negative 0.1% impact, which is pretty close to that 0% that we would expect. The Woodridge pay increase is scheduled to end in July of 2025 based on their monthly narratives. Budget to budget, that may have never been included in the modeling since it was only from January to July. Medicare reimbursements are modeled at 0.8% overall. The table above outlines changes based on inpatient, outpatient, and professional. So we can see that for Medicare, inpatients down 1.4%, outpatients up 3.4%, and professionals up 1.3%. So that blended average is what's getting us to the 0.8. And in the narrative, they say that the biggest drivers were the wage index changing for their inpatient and outpatient. Looking at things CVMC is requested to be held harmless for, they're not requesting to be held harmless and represents that they have met the benchmarks. However, in other requests, they have included H.266 as part of their rate decrease. So again, that's that negative rate. However, again, have asked for the 3% charge master increase. And when we back that out is what we get to that 2.3% increase in rate. So looking at their utilization, starting with the left side, you can see overall CVMC is expecting a 2% growth in NPR due to utilization. They're expecting a drop in inpatient utilization of 1.5%, a 3.5% increase in outpatient, and a 3.9% increase in professional. There's also a 1.3% drop in other, which in the rate decomp they have labeled as their SNF facility or Woodridge. In their narrative, they also note increasing demand in imaging service, endoscopy in the operating room. They mentioned an unexpected boost in PET imaging because they had a mobile vendor that they were unsure of their reliability, but they were able to offer over 400 PET services in FY25 and expect to provide 500 in FY26. They also referenced different procedures due to their linear accelerator replacement, but that is now back up and running. Then looking at the right side, we have utilization based on reported stats. So for CVMC, we have 24 actuals, 25 projections, and 26 budget available. We can see in acute patient days, it's experiencing a decline. This would include inpatient psych, so that would be someone expected. SNF is budgeted to increase quite a bit. This doesn't quite align with the budget to budget breakdown in the rate decomp. However, this is projections to budget, so there may be some differences, and there isn't always a direct tie in the utilization impact on NPR compared to the changes in statistics. Nursery days, which again make up a very small percent, we can see it's about 1%, are expected to jump by 11% in this one. So then overall inpatient days are expected to increase by 10%, which is again mostly driven by SNF, offset by the reduction in the acute inpatient psych. And then for outpatient and ancillary, we've got 5 to 8% increases overall, except for that all outpatient visits, which is just slightly above flat at 0.5%, and ER, which is projecting a slight decrease at negative 0.6%. Looking at their labor assumptions, so their average labor expense inflation factor at CVMC is 5%. So this is primarily driven by current and recently negotiated first union contract obligations. So we can see on the left here, looking at the year-over-year growth, we're seeing a 5.5% increase for physicians. We see the locums reducing, and we know that that's related to their effort to reduce travelers. 7.1% increase in nursing, 5.6% for contract nurses, and then for all others, 8.3%, which ends to a total blended average of 5.2%. For non-clinical, there's a 13.1% growth year over year. And then looking at their traveler FTE summary, we can see that those locums and contract staff nursing are both dropping by 3 and 23 respectively. CVMC did provide labor assumptions budget to budget and broke out benefits separately, so those have not been included in the average. CVMC also noted in their narrative a reduction of 23.2 traveler FTEs, which equates to a cost reduction of about $3.4 million. We're seeing the largest clinical drops in inpatient services on the right there, as well as physician office practices. If we drill down into this, it appears to be driven by SNF, which has a drop of 13, and psychiatry a drop of 5 for inpatient, which again is similar to what we were seeing on the previous slide. For physician office practices, the largest contributor is a drop in family medicine of 9 FTEs. And as a reminder, CVMC has closed 2 of its 5 primary care offices into FY25. Looking at the non-clinical drops, we see that general services include fiscal services or 6 FTEs, nursing admin at 2, and other administration at 3 FTEs. And physician office practices also included a drop of 12 FTEs in medical group administration. And in the response to the RFI, they stated that this reflects staff vacancy savings for ambulatory practices. So this is, again, looking at the XCC, that comparison of base salaries and total comp for the hospital's executive and clinical leadership with those of their lowest paid employees. So this is a direct response or provided by the hospital. So we can see that their lowest paid salary is nursing support. On an annualized rate, it's about $44,000, a little closer to 45. And so if we compare that to the average annual salary of the executives at CVMC, we could see it's almost a 7-to-1 ratio, or just under 15%. Looking at operating expenses in blue first, we'll start here. We see that every year except for FY21 since 2017, which again, FY21, we're looking at peak COVID, CVMC has exceeded its operating expenses each year. When we look at operating revenue, we see historically CVMC has been unable to realize their operating revenues up until FY24 starting in 2018. The FY24 overage is about $25 million, of which about $24 million is separately being considered for enforcement. And then looking at that line graph, we see that historically expenses have outpaced revenues, again, with the exception of FY24. Starting here at the top with commercial, again, we see historically CVMC is over budgeting commercial. This is by as much as 16.7%. The same is true for Medicaid, although in 2023, we're seeing it was under budgeted significantly, and actuals came in over budget by 18.4%. Medicare overall appears to be closer to budget. It was over budgeted slightly in 2018 to 2021 before being under budgeted in 2022 and slightly under budgeted in 2023. So if we're looking then at the right on those FY25 projections, we see that they are over commercial by 6.7%, under in Medicaid by 3.8%, and then Medicare and uncategorized is pretty much at budget. So this comes into an overall overage of about 3.5%. So starting on the left here, we can see that despite budgeting for a positive operating margin from FY17 to FY23, CVMC was unable to generate that. However, in 24, they budgeted a negative margin and actually were able to generate a positive margin. FY25 projections show income and margins lower than budgeted. And then if we look at the right, we can see that FY24 NPR and other operating revenue came in well above budget. And even though expenses similarly came in above budget, it was at a smaller rate, which allowed them to generate that positive margin in FY24. We see here again that operating income has come in under budget every year from 2017 to 2023. Notably, most years NPR is below budget as well, while other operating revenue is above budget. And every year except for FY21, operating expenses have come in above budget as well. Looking at starting at the top of their days cash on hand, we see that there was a significant drop from between FY21 and FY22 from 114 to 69. Since then, it has increased and it appears right now to be hovering around 70 to 80. This is considered highly vulnerable according to the S&P Global Ratings. Days in patient accounts receivable has increased year over year from 2017 to 2022, and then saw a significant drop by over 20 days in FY23. Since then, it's continued to drop and now is in the average performing range and is actually creeping closer to that above average performance, which is below 30 days, as they're currently sitting at their FY26 budget at 36.8 days. Their age of plant has continued to increase year over year and is now budgeted at 21, and this is considered highly vulnerable according to the S&P Global Ratings. The first note here I want to start with is that those really high numbers that you're going to see over there on the right for Cigna and United, those are due to being paid at a case rate. And so that, it was encompassing of the entire service, so they're not comparable to the others. We've removed them in future slides for calculations. The second note is that CVMC charges and is reimbursed the same for PT evaluations, regardless of the complexity of the evaluation. So you can see the low, medium, high, the gross charge is $322 regardless. And then finally, what we can see here is that there's significantly lower reimbursement for United for those two labs here compared to other payers. We can see that those are at 10 and 19% compared to the others, which range from 55 to 94%. We again see some evidence also of more variability in Blue Cross Blue Shield as a percentage of gross compared to the other payers. So again, I want to be clear that we've removed CVMC from the calculation of the Cigna min, average, and max for ED visits due to being paid at that case rate. But for the others, we see that there's more consistency across both payers in terms of being above or below average. Whereas, for example, in Copley, we saw that there was differences between Cigna and Blue Cross. Here, they at least seem to follow the same patterns. So PT evals and CT scans are lower than average for both Cigna and Blue Cross, while remaining CPT codes are higher than average. But none of their negotiated rates are either the highest or the lowest in the state for either payer. Looking at the shoppable services requirement, we see from the screenshot on the left that specific insurance information is required to get an estimate with insurance. So this is not a problem officially with the CMS rules. However, when that information is supplied, it changes that amount you pay. So you can see over there on the right, it's got total fees, hospital fees, the amount the insurance covers, and then the amount you pay. However, there's no clear statement of the negotiated rate or the min and max allowed amounts. Those are also not supplied. So while you are able to select the services and select the payer, there's no typing in everything and there's no private PII required. There are those missing elements for CVMC, so they do appear to be non-compliant with the shoppable services, however, compliant with the machine-readable file requirements, and this is the same across all three VM Health Network hospitals. Looking at their payment to cost ratio, we can see that for inpatient, CVMC is and has historically been below the average, and in FY24 sits at 111%. Medicare has been at or above the average and is at 104% for FY24, which notably is the only hospital to have Medicare at or above 100%, kind of ignoring cause for their cost-based reimbursement. And Medicaid sits slightly above average at 71% in FY24. Looking at outpatient, we see a pretty similar trend in commercial, but obviously higher payment to cost ratio at 192%. Medicare and Medicaid are both fairly close to their average, and they sit around 65 and 61% respectively, which is obviously much lower for Medicare for outpatient than inpatient, where we saw that 104%, which drops down to 65% for outpatient. Looking at their work reviews and productivity on the left, we see that 43%, it's kind of easiest to read this like a clock going from increasing productivity. So 43% are below the 25th percentile, 42% are in the 25th to 50th percentile, 10% in the 51st to 75th percentile, and then 5% above the 75th percentile. So generally what we can see from this is that 85% of FTEs are at or below the 50th percentile. This is worse than last year. Last year we had 70% of FTEs at or below the 50th percentile. And of those 29 services reported both this year and last, 8 have improved while 1 has worsened. It's important to note that there were some differences in reporting from this year to last, which may explain why productivity overall has worsened, yet more services have improved rather than worsened. Those could also be explained by having less FTEs attached to them. For example, the one that's worsened is emergency medicine, and that does have quite a large number of FTEs attached to it compared to some of the other groupings. Looking at overall average length of stay, we see total has decreased from 22 to 24, but is projected to increase in 25 and budgeted to increase even more in 26. Acute average length of stay has decreased year over year, and the nursery average length of stay has pretty much stayed consistent, decreased slightly overall. SNF average length of stay, which again, not shown here because it skews the graph significantly, has decreased overall from 126.76 in FY22 to 106.03 in the 26 budget. There was somewhat of a spike in FY24, and it is budgeted to increase slightly over 25 projections. Looking at access, starting at the left, we can look at the wait times. We see 38% are scheduled within 2 weeks, 14% in 2 to 4 weeks, 35 in 1 to 3 months, and then 7% in 3 to 6 months. And those remaining patients, those 6% of remaining patients are assumed to have been seen after more than 6 months. Of the 28 services reported this year and last, 13 have improved and just 4 have worsened. However, notably, 3 of the 4 services whose wait times have worsened are primary care practices. And then again, looking at the chart on the right, we see that more zip codes have increased their market share compared to 5 years prior. One note is that all of these listed have more than a 50% market share, and 9 out of 10 of them are higher than 60%. Waitsfield is the biggest drop in percentage at 7.2% compared to 5 years prior. Finally, looking at CVMC quality, their current star rating is 2 out of 5 stars, patient ratings at 3 out of 5. The star rating was at 5 stars in Q4 of 2022, was 3 stars earlier this year in April, and has now dropped to 2 stars. So we're continuing to see that decline. Looking at that top right graph, we see that CVMC got a payment bump for their value-based purchasing program of 1.27%. They saw a payment reduction, however, of 1.17% for readmission reduction program and 1% reduction for hospital-acquired condition reduction program. The bottom right graph is looking at some of the ED metrics, and so we see average times patients spent in the ED before being sent home was 176 minutes, which is essentially on par with the national average and slightly lower than the state average for other medium volume hospitals. The median time that psychiatric and mental health patients spent in the ED before leaving is 522 minutes, which is higher than the national and state averages. And finally, the percentage of patients who left the ED before being seen is at 1%, which is lower than both the national and state average. Looking at the CVMC staff recommendation, so looking at NPR growth, 14 of the UVM Health Network executive positions were directly comparable between the 25 and 26 budgets. That 9% year-over-year increase was budgeted, which totaled about $695,000, or roughly slightly less than $50,000 per position. So staff is recommending that CVMC's budget by the reduce the CVMC's budget by the hospital's approximate allocation of this increase, which is just under $64,000. The rate then, staff recommend reducing their rate from a proposed 3% of the 2.9% to account for this rate impact of that NPR reduction, as well as a expense decrease commensurate with NPR reduction. And I think that's all for us for CVMC, and I'll turn it back to you, Chair Foster.
Thank you. You may not know the answers to this right now, but 2 questions. One, recall when we looked at the network in the budget hearing, the network had, I think, around $250 to $270 million in assets at the network. Do you know how much, if any, of that $270 million should be attributed to CVMC?
I don't, Chair Foster, but I think a way you could approximate it was similar to how they allocate shared services and allocate according to total revenue or some other methodology like that.
And relatedly, I remember we got some questions back. We had asked about the network assets. And if I recall correctly, there was a $50 million transfer from the medical center to the health network, maybe around 2018. And then there was several hundred millions of dollars in debt proceeds that went to the network assets. And the service on those debt proceeds were paid by at least UVMMC. Do you know whether or not CVMC has to make any payment to service the debt proceeds that went to fund the network assets?
I don't, but we can get back to you on that.
Okay. All right. I have no other questions. I'll turn it to the others. Thank you.
This is Tom. Matt, thanks for the presentation. I also have a couple questions about operating expense growth. It appears that that's been outpacing revenue growth at CVMC for several years now. Am I reading that correctly?
Yeah, expenses have been outpacing revenues in the past several years, with the exception of FY24.
Thank you, Emma. Are contributions to shared services considered part of operating expenses?
They are, yes.
Okay. in your recommendations, you recommended a reduction in operating expenses commensurate with reduction in NPR growth. Did you consider further reductions in operating expenses because it has been growing faster than revenue?
Yeah, we've considered it that way. We don't have any specific recommendations for cuts to shared services or explicit recommendations, but we have compared the growth there.
Okay. Okay. That's all. Thank you.
This is Sarah. I do have some questions, mostly for clarification. So how does the CVMC proposed mid-year adjustments play into the FY26 proposals?
So it's included in that negative 3.6% that they submitted. However, we believe it's been removed for the 2.3% that's taking away the 23, or excuse me, that's taking away the enforcement overage as well as the H.266 impacts. For FY26, there should be an impact because again, it's that initial mid-year is going to come into effect for those first 3 years. Matt, I'm not sure if we have specific numbers on how that's impacting the 26 budget, but we do know that it is having an impact.
Yeah, we can follow up and provide the specific amounts for the impacting the 26 budget. Yeah.
Okay. And then I was curious whether the CVMC's shared service contributions also go towards the increases in salaries for network employees.
Yes.
And is your proposal for the total amount of their contribution to all shared service salary increases or just those for CVMC employees?
I'm sorry. Our recommendation is for the CVMC's allocation of the executive compensation increases. So not all health network employees, just those, I believe it was 14 that were specifically identified on the earlier slide.
Okay. And then, so that's the only piece of shared services you're recommending a change to, not for other shared services such as I can't think of any right now, but you know, they've contributed a lot for other costs of the network. And then just to clarify, when I asked my first question, you said it's taking away. I guess I still am a little confused about what the mid-year change, which is only temporary in FY25, is impacting the FY26 budget. So maybe we can follow up on that later,
Yeah.
but I'm still not sure what taking away means.
Right, but what I mean is, but for that mid-year adjustment, the FY26 NPR will be higher. Like in isolation, that's decreasing the 26 NPR.
Even though it's only temporary, 3 months.
Yes.
Okay. All right, that's all my questions. Thank you.
Just 2 quick questions. Do we actually have confirmation that the mid-year rate reduction took effect August 1st?
No, I do not have confirmation. No.
And this actually applies to all 3 UVM Health Network hospitals. But did we get the purchased services breakdown for each of those 3 hospitals? Expenditures, how they were allocated for consulting services, for external relations, for legal services outside the hospital. Do you know I guess I would ask, if we haven't, can we make sure that we have? I didn't see it in the follow-up questions, but I would like to see that. So if we haven't gotten it, thank you. Thank you.
Okay, anything else from the board? I'll turn to the healthcare advocate.
Nothing from us on this one, Chair Foster. Thanks.
Okay, and Ms. Noonan or Ms. Patnode, if you're here and have any comments, you're welcome to make any now, or of course, wait.
Yes, thank you so much, Chair Foster and members of the Green Mountain Care Board for the opportunity to comment. We are going to be reviewing the recommendations a little more thoroughly so that we have a more complete understanding of what's been presented today and how it will impact our organization and those we serve. So we'll provide additional comment and information in writing prior to your vote next week. And again, thank you for the opportunity to provide some feedback to you.
Thank you very much, and thanks for taking the time to provide that feedback to us. It's an important part of the process, so thank you.
Of course.
Okay, why don't we just take a quick 5-minute recess just so we can get Member Merman back as we move to Porter next. So brief 5-minute recess. Thank you. Okay, Member Merman, are you back? Great. Okay, we can resume.
Forgive me, a lot of slides. Yes, load them all. Every time we share it. One more second. All right. So moving along to Porter, I will pass it along to my colleague, Janelle Vigario.
Right. So similar to CVMC, Porter's submission was complete and on time, and they were timely and responsive in follow-up requests and questions from our staff. The legislative impact, Act 55 Porter is impacted by Act 55 since they are part of a network. They estimate that this could have a negative impact of about 2.5 million for 26. They did, however, take on additional NPR and pediatric dental OR, which was originally housed at UVMMC. I don't know the payer mix breakout of that, but they estimate the NPR impact is about equivalent. Variable pay for Act 68 is based on the goals set on a mix of priorities that are linked to strategic goals of the organization, patient and employee experience, financial quality, etc. But they noted that for 25, the networks board has determined there will be no payment for variable pay. And for Act 111, they state that they are seeing a slight reduction in workload, but since it started on 1/1, there wasn't much actual experience to determine the impact on the prior auth FTEs. There's still research required by the prior auth team as well, so they haven't reduced their team yet from that. Move right on to benchmarks. The Porter is hitting all of their benchmarks, 3.5% NPR growth. They've requested a 3% commercial reimbursement rate and a 2.4% operating expense growth. For NPR growth, Porter is hitting the benchmark at 3.5%. We'll dive into the rate on later slides, but you can see that they are expecting increases in rate, payer mix, utilization, with an offset in other. The large offset in other is due to Medicare. In the narrative, they state that an adjustment in cost reimbursement in the latest cost report was happened because of a slight drop in patient volume. For Porter's request to be held harmless, Porter represents that they have met the benchmarks, and we think so too. So there's no special request here. Straightforward. So the maximum reimbursement rate is 3%. The overall, the overall impact on commercial NPR to the system is 4.4 million. That's driven by utilization and rate with a slight offset in major commercial payer mix and other. As a reminder, H266 is not modeled here, and although they are taking on additional NPR, it might not all be commercial. So this could be a little overstated, but that's just my opinion. That they didn't say that. For budget assumptions, public payer budget assumptions on the next slide. We see that Medicaid is noted as a 0% in the narrative, and it's very close to model that 0% in the rate decomp at negative 0.1%. Medicare and Medicare Advantage are modeled at 3.2%. Since they are a critical access hospital and have cost-based reimbursement, that increase is close to reflective of the increased cost. Moving on to utilization, they are expecting 5% growth in NPR due to utilization. They are expecting increases in inpatient, which aligns with the growth in their acute average daily census and the birthing center, which they spoke to in the narrative. Outpatient is also expecting growth, budget to budget, and NPR. In the narrative, they have a table with MRI, CT scan, OR cases, and billed lab tests increasing. Professional revenues are anticipating a decrease in utilization. This is spread pretty evenly across all payers. I don't have information on what's going into that assumption. However, professional services overall is anticipated to grow about 4% in terms of NPR. And also in the narrative, we do see medical group professional work RVUs increasing 6% budget to budget. Swing, it's showing a large decrease from budget to budget. But they explained in the 8-4 budget follow-up that the staff sent out that projected the budget. They're expecting an increase due to case management integration with the UVM Health Network. On the right side, we have utilization based on that adaptive entry. And for Porter, we have the actuals projected in budget. Swing patients are showing an increase, but this could also just be considered a rebound from lower than expected volume in 25. As mentioned, staying on that utilization table, as mentioned earlier, acute patient days are expected to increase. They're aiming to increase their average daily census. And for outpatient, the largest areas of growth is operating room cases. This has been an area of growth for them in 25, and they expect to keep that volume in 26. For labor, in the narrative, they note that the inflation factor is 3.8%. They mention inflation adjustments include position-specific increases, such as negotiated union contract raises, market-driven salary adjustments, and general merit cost of living increases. One thing to note is in their 26 budget, they're aiming to reduce travelers by 15. And then taking a look at their FTE sheet, we see the largest drop in ancillary and physician office practices. Drilling down into that FTE report, it appears to be spread across multiple departments, including ER, lab, drug sold, operating room, as well as the recovery room. And for the physician office practices, it's driven mostly by family medicine, which is 5 FTEs, medical group administration, other physician departments, and radiology, which were each 1 FTE. This was offset by women's, which was increased by 3. For non-clinical, the drop in general services is in fiscal services, and the drop in physician office practices are in the medical group administration, which is dropping from 5 to -1 FTE, which we saw this with CVMC as well. It represents a space to apply impact that haven't been allocated across individual cost centers yet. Jumping to salaries, this was what the hospital provided. The lowest paid salary is nursing. The medical assistant, on an annualized rate, this ratio is 9-1, which is just over 11%. Moving on to their previous assumptions, starting with operating expenses in blue, we see that 22 and 23 appear to be somewhat of outlier years compared to previous, and 24 exceeding its budget by over 7% both years. On the operating revenue side, Porter tends to exceed its budgeted revenues except for 20 and 24. Looking at the line graph, we see the bigger budgeted margins as evidenced by the space between the 2 dashed lines. We also see revenues consistently higher than expenses, indicating a positive operating margin. 23 appears to have the largest deviation from budget for both operating expense and revenue. They have some strong financial performance there. Moving on to the by payers, starting with commercial, we see that Porter has historically over budgeted revenues for commercial and been unable to realize their NPR, with the exception of 23, where they exceeded budgeted revenues by over 10%. For Medicaid, we see that most years Porter has come in higher than budget, ranging from 7.8% to over 20.5%. Notable is in 20, they were below budget for Medicaid by over 23%, and similarly below budget in 23 by over 10%. And in 20, finally, we see that Medicare revenues have been under budgeted every year since 2017. Looking at previous assumptions, starting on the left, we don't see a lot of red for Porter, which kind of we would expect that based on that line graph that we saw. Most years have both a positive operating and total margin and income. The only deviations from this is for the operating income and margin in 2018 and total margin and income in 22. Looking to the right, we see that NPR and other operating revenue typically come in above budget along with operating expenses, though not always in the same year. We see for 24 that NPR came in below budget and other operating revenue came in above budget and expenses came in above budget as well. This led to $3.6 million less in operating income than budgeted, though they were still at a positive operating margin for the year. Looking at their ratios, starting with days cash on hand, we see that Porter did dip below 100 in 23. However, they have recovered and now appear to be hovering around 110. This is considered adequate according to S&P Global Ratings. Days in patients' accounts receivable have been dropping fairly consistently since 20, going from 81.3 in 20 to 37.1 in 26. This moves Porter from below average performance to average performance and is now closer to an above average performing metric. This is good news. The age of plant dropped significantly between 22 and 23 from 15.8 to 4.1. 15.8 is considered highly vulnerable. However, for 26, they are budgeting 6.3, which is considered very strong. This is another great trend and is one of the lowest age of plants in the state. Taking a look at their transparency file, just a quick thing to note that for values greater than 100% for Cigna, it's due to being paid at a case rate. The second note is that Porter charges and is reimbursed the same for PT evaluations, regardless of the complexity of the evaluation. And there's more consistency across the selected services in terms of percent of gross for MVP, Cigna, and United compared to the variability of Blue Cross Blue Shield. And moving on to the cross-hospital comparison, we look at Blue Cross and Cigna. We see overall Porter is lower than the averages for most of the selected services. Note again that we did take out Porter from the calculation for those ED visits where they are paid at a case rate, which is interestingly they have for their lower levels of complexity, but not for the two highest. We do see that colonoscopies are higher than average, especially for Cigna. Porter has the lowest negotiated rate for all ED visits, except for the highest complexity for Blue Cross Blue Shield. Similar to CVMC, Porter appears to be non-compliant with the shoppable services and compliant with the machine-readable file requirements. So I won't spend too much time on this one. We can jump to the payment to cost ratio. Looking at this, we can see that for inpatient, Porter has historically been above the average, though they are just about average at 144% in 24. Due to cost-based reimbursement, Medicare is at 99%, which is above average. And Medicaid also has historically been above the average, but now sits at about average at 55% in 24. For outpatient, we see that commercial is below average at 182% in 24. Medicare is at 99% and Medicaid is a little above average at 63%. The biggest differences for Porter from inpatient and outpatient comes from the commercial payers. Medicare is to be expected at 99%, and Medicaid is about the same for both inpatient and outpatient. Moving on to productivity. Looking at work RVUs on the left, we see that 43% of FTEs are below the 25th percentile, 41% are in the 25th to 50th percentile, and 10% are in the 51st to 75th, and 6% are above the 75th percentile. This means that 84% of FTEs are at the 50th percentile or less. This is slightly worse than last year when 79% of FTEs were at or below the 50th percentile. Of the 16 services reported this year and last, 4 have improved and 4 have worsened. So overall productivity appears to be about on par with last year. It's important to note, though, that there was some differences in reporting from last year to this year. Looking at the average length of stay, we saw a spike in 2024. We don't have information on this trend for 25 and 26, but we can say that acute average length of stay is fairly consistent from 22 to 24, while nursery has decreased slightly in that time. We plan to reach out to ask Porter if they can provide an update for this, something that just kind of slipped through the cracks. So looking at access, if we start on the left, looking at wait times for hospital-owned services, we can see that 32% are scheduled in 2 weeks, 26% are scheduled within 2 to 4 weeks, 24% are scheduled in 1 to 3 months, and 18% are scheduled in 3 to 6 months. Of the 11 services reported this year and last, 4 have improved and 4 have worsened. And note that 2 of the 3 primary care wait times have worsened, while the third has improved. Looking at the chart on the right, we see some very large swings in the market share compared to 5 years prior. Middlebury has dropped by 11%. Orwell has dropped by over 20%. Salisbury has dropped almost 40%. There are some increases in both Brandon and Shoreham, as well as some small increases in Bridport. Moving on to quality. So their current star rating is 3 out of 5 stars, and the patient survey is also at 3 out of 5 stars. Their star rating in Q4 of 22 was 4 stars. In April of last year, it dropped to 2, and now it's back up to 3. The bottom right graph is looking at some ED metrics. We see the average time patients spent in the emergency department before being sent home was 161 minutes. Which is on par with the national average and lower than the state average overall. The median time the psychiatric/mental health patients spent in the emergency department before leaving is 204 minutes, which is lower than the national and state averages. The percentage of patients who left the ED before being seen was not available for this period. And moving right to staff recommendations for NPR growth. 14 of the UVM Health Network executive positions were directly comparable between 25 and 26 budget. A 9% year-over-year increase was budgeted for these positions, totaling $695,000, for an average of $49,641 per position. Staff recommends reducing Porter's budget by the hospital's approximate allocation of this increase, which worked out to $28,649. For rate, staff recommends reducing Porter Hospital's commercial rate by 0.1% from a proposed 3% to 2.9% to account for the rate impact of the previously discussed NPR reduction. And for expense growth, staff recommends an expense decrease in line with the NPR reduction of $28,649. Turn it back to you, Chair Foster.
Thank you very much. I'll just open it up to the board members.
I am happy to start first. I guess I just really wanted to look at slide 126 again, if you could, Janelle. So when I look at this slide, and I just want to see if I'm interpreting this correctly, but it looks like for several years, Porter has underestimated the amount of money they were going to get from Medicare, and to a large degree Medicaid. And my question is, for anyone on the hospital budget team, how do you think that impacts their prediction for how much they would need from commercial rate? I guess it's a retrospective question, so it's not specific to this year's budget, but looking at the prior budgets.
Dave, I'm sorry, I missed the first part of this. Your question was how is can you say it one more time?
How does the under budgeting of Medicare and to a large degree Medicaid with some outlier years impact their, how they approach to budgeting commercial rate increases? How does that under budgeting of Medicare impact their commercial rate request?
Yeah, so the way they build up to their commercial rate ask is by assuming expense increases, assuming public payer revenue increases, et cetera, NPR generated from that. So if they underassume how much they're generating from the public payer, all else equal, they're going to have to increase the amount they ask for in commercial rate. Under budgeting public payer revenue could have an impact of asking for additional commercial rate they might otherwise not need.
So then they end up getting less commercial revenue in many of those years than they budgeted. But they had positive margins for many of those years. So is it to assume then they were able to make the positive margin off of that Medicare reimbursement then, as opposed to the because of the lower commercial rate? Sorry, let me just finish it there. Is that what's going on? Is the positive margins being driven by the Medicare reimbursement?
There's pretty significant variance between their budget and their actual Medicare. What's driving the under budgeting, I think, is a little bit harder to say definitively.
All right. The other question I had, Janelle, I think this may be for you or for anybody else. I think you mentioned that they discussed that they had a drop in volume on the Medicare cost report. Is that right?
Let me hop to my notes.
It was in and around the discussion of the rate and utilization increases.
So it says in their narrative, they speak to an adjustment in cost reimbursement in the latest cost report due to a slight drop in patient volume. Yeah.
Okay, I'm trying to understand when you said that, and then soon after that, there was a slide showing a 5.7% increase in utilization. Can you help me understand how they have a loss in volume but an increase in utilization?
So that utilization on slide 120 is in regards to the commercial utilization. The other NPR growth, when I look at the NPR growth from slide 118, that is for all payers rolled up. And that big dip is from Medicare. That's when I look at the rate decomp, it's really driven by Medicare. So, and I'm not an expert on Medicare reimbursement, but I can get a little bit more detail on that one.
That's right.
I'm not sure if it's a look back with the reimbursement or if it exactly how that works, but that's a good follow-up, I think.
Yeah, I'm just trying to, as you were talking through this, that, and then you talked about the increase in OR cases, it seems as if there's a shift to decreasing Medicare volume, increasing commercial OR volume, and I think I'm just trying to understand that dynamic through this. If that's I mean, it's hard to say. I think it's, we're trying to putting together a bunch of different graphs and charts into one, but that was sort of my takeaway, and I was just trying to figure out if that's you think that's a reasonable interpretation of that data.
I'm not exactly comfortable saying that. I'd rather follow up on that. I know that Porter lost a provider, right? That might have impacted some sort of reimbursement, and then they got it back. So I'm not exactly sure what's happening there, and I don't want to say something that would
I totally appreciate
be inaccurate.
That. Yeah. Sorry, I'm just trying to sort of ask questions to clarify my thoughts. So thank you. That's all I have for now.
Any other questions or comments on Porter? Okay, great. Anything from the healthcare advocate?
Nothing from us, thanks.
Mr. Ortmeyer, do you have any comments at this time?
Hi, thanks, Chair Foster. Yeah, just I have no further comments on the recommendations. Thank you. But I did want to just point out in some of the staff's review of the age of plant, I wish we were at 6 years, and that's something that we need to look into as to why it's being reported that way. Because that would suggest that we've had a lot of infrastructure updates, and we've not. So we need to look at that, and we can update the board further on that once we figure out what was going on there. So thank you.
Yeah, that would be great. Just I don't know where we get the data on that. Do we get it from, where do we get the data on age of plant?
Yeah, it's directly from Porter. So we can look at it quickly again. What's driving this huge apparent decrease in age of plant for them is, looks like if you look at between 22 and 23, there's like a $36 million decrease in the accumulated depreciation. So that suggests to me maybe some asset fell off of the balance sheet or was removed from the balance sheet, maybe reduce that accumulated depreciation. But yeah, we love more clarification about specifically what happened there.
Okay, great. Well, thanks for raising that, Mr. Ortmeyer. Okay, we can move on to UVM.
Thanks, Chair Foster. UVM submission was complete and on time. I want to thank UVM staff. They were timely and responsive in follow-up requests and in answering questions that staff had. Beginning here, Act 55, the impact of Act 55, their response was it's estimated using calendar year 24 as a base year, which should be noted as different base period compared to that used in the FY26 budget development. It demonstrates both the annual impact payers will experience through 26, along with the 9-month impact of UVM Medical Center's FY26 budget due to the January 1st effective date. So 12-month impact, $94 million decrease. FY26 budget year impact, $70 million, almost $71 million. Act 111, similar to the other network hospitals, that the same response here went into effect on January 1st, so not much actual experience to determine the impact. They're seeing a slight reduction in workload, but the prior auth team must still check sources for waiver eligibility and research denials, which is impacting their ability to reduce FTEs. In addition, the prior auth waiver does not apply to all payer benefit plans and adds additional layer of work and risk of human error. In an upcoming engagement with the consultant, they're seeking opportunities to find efficiencies in their prior auth process. And then in response to the variable pay question, they determined through goals set by senior leadership, the goals are determined, set by senior leadership and approved by the compensation committee. Variable pay goals are a mix of priorities linked to strategic goals of the organization, but they did note that the networks board determined there will be no payments for variable pay and So looking at UVMC's benchmarks, their NPR growth was, after adjustments, was under benchmark. Commercial rate growth similarly under benchmark. Their operating expense growth was over benchmark, which I will discuss on the following slide. You look on the right-hand side, the top is how we are calculating their expense benchmark, where we are taking the FY26 provider transfer amount and deducting it from the from 26 and deducting it from the FY26 expenses, and then doing an adjustment for the provider tax associated specifically with that transfer. And if you do it that way, we're seeing about a 3.19% operating expense growth. Slight difference if you do it the way UVM is calculating it, where they're taking the FY26 expenses from the provider transfer and then deducting them from, increasing the FY25 base amount by that amount, and then calculating the percentage increase off of that. We do not believe this is the correct way to do it, and they're technically over the expense benchmark. Their NPR benchmark, you'll see on the left, after adjustment for the provider transfer, is 2.2% over prior year, which is below the benchmark. On the left-hand side, you can see their submitted and approved commercial rate history. I'll note for UVM, unlike some of the other hospitals where we largely approved change in charge in the periods prior to FY25, for the medical center, these reflect commercial effective rate, as I believe we referred to it at the time. And on the right, you can see the build up to their NPR growth. I'll note that 4.4% is higher than the amount shown on the previous slide, because this is the actual NPR amount and not the reduced amount for benchmark purposes. So 2.6% of that is due to rate decrease. This is due to rate, 0.1% payer mix, nearly a 6% increase due to increased utilization, and 0.9% other. I'll note the other is their budgeted actuals collection rate. So essentially, the rate of payment from all payers is nearly 1% better than they had originally budgeted. Looking to the commercial rate benchmark, on the left-hand side over here, you can see how you build up to what they've referred to as their negative 7.9% commercial rate. That includes the mid-year rate increase and pharmaceutical pricing reduction, or the Act 55 reductions as well. So their actual rate increase they're requesting is 2.4%. That these up here. UVM stated in their narrative that they're not asking for a reimbursement rate for FY26. They're instead asking for a 3% charge master increase. We disagree, and we think that's reflected here. The bottom table reflects both the commercial NPR growth, the impact on the system. We separated out H266 enforcement and mid-year for this exhibit. So rates contributing 2.5% of growth to NPR. This includes major commercial and other commercial. Payer mix is increasing by 2.2%. Largest driver is utilization at 6.9% NPR growth. And as stated in the prior slide, other budget actuals collections, meaning commercials paying better than anticipated, and the result of that is 2.4% NPR growth. Overall NPR growth would be 14% after applying the mid-year decrease, enforcement, and the impact of Act 55, which brings down the commercial NPR growth to 4.3% overall. Here's a slide showing UVM's net patient revenue as a percent of the system proposed FY26 budget. So starting from the left, you'll see Rutland, their budget to budget request is a $5.9 million decrease. Northwestern, a $2.6 million increase. Gifford, a $1.7 million increase. I won't read all of them, but UVM's is an $83.1 million increase. So though they reflect 52% of the system net patient revenue,